Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good morning to everybody. Welcome back to our emergency medicine seminar series. Today we are going to conduct the part 2 of the seminar, which is on clinical toxinology. So we will have similar lineup of 4 speakers and 2 moderators. So I will first introduce to you our 2 moderators for today. The first one is Dr. Daniel, and the second one will be Dr. Muhammad Hafiq, and both are also our emergency medicine trainees in the National University Hospital in Kuala Lumpur. So I would like to also introduce you to our 2 hardworking program managers, which are Dr. Kevin Wong and Dr. Liana. So without further delay, let me pass this session to our 2 moderators to introduce our speakers. Thank you.
Okay. Bismillahirrahmanirrahim. Assalamualaikum and very good. Okay. Good morning. Good morning to everyone present. We have our panel of speakers here today. Our chairperson, first of all, Professor Ahmad Khaldun, and our panelists, Dr. Anas Amri Hashim, Professor Sataria, Dr. Vanessa, who I think will be joining us a little bit later, and Dr. Patrick Tiglao. I'll be the moderator for today. My name is Dr. Daniel Ikram, and my co-moderator here is Dr. Hafiq Hamid. Okay, so thank you for joining us here today for the second part of the third emergency medicine seminar series, being broadcast on Zoom and also StreamYarded to Facebook. Just before we begin today, there's a few housekeeping announcements to the audience on the Zoom platform. If you have any questions, please type them into the designated Q&A box, okay, not the chat box. And the Secretariat will sift through your questions at the end of all the talks and field them to the speakers as appropriate. Number 2, for your e-certificates, to get your e-certificates for attending the seminar, please fill in the feedback form, which the link to which we will display at the end of the webinar. And please get your identification details and your email correctly, so that there won't be any mishaps in issuing the certificates. People who are watching the seminar from Facebook can type in your questions in the Facebook chat box. Just the ones on following us on Zoom, type it into the Q&A box. Yeah. And then the QR code for this is specifically for Malaysians. The QR code for scanning points on the MMA application will also be displayed at the end of the webinar. So stay with us, and we will display the code later. So for those of you who aren't able to follow the webinar on Zoom due to the limited capacity, you can follow us on the Facebook page, CPC Faculty of Medicine UKM. Yeah, type that in as displayed on the screen, and we will be streaming live from Facebook as well, so you can follow us there. Okay. Without further ado, I think we'll go on to the panelists for today. So the format is going to be similar to last week's format. There will be 4 speakers, and each speaker will speak will give his or her talk for about 30 minutes on a variety of topics, and we will have 2 breaks, one after the first and second speaker, and another one after the third and fourth speaker. And then we will field questions to the speakers. Okay, so questions we will not be taken at the end of every talk, but only after all the 4 talks are done. Okay, so as to allow for a more lively discussion. Okay, so our first panelist for the day is Dr. Anas Amri Hashim from Sarawak, land of the Kenyalang. He's currently in the head of department of the emergency head of the emergency medicine department in Hospital Sarike, and also an adjunct lecturer for in Segi College. He also has an interest in his areas of interest are pediatrics emergencies and also emergency and critical care ultrasound. So he will kick off the session today by giving his talk on snake-related injuries. Okay, Dr. Anas, floor is all yours.
All right. Bismillahirrahmanirrahim. Assalamualaikum and a very good morning. First of all, I would like to thank. Can you all hear me clearly? Okay. All right. Okay. Good. All right. So first of all, I would like to thank the organizer for giving me this opportunity to talk about these snake-related injuries. Okay. All right. Thank you first. Thank you also to all other fellow Rex consultants for sharing their references and data for my presentations. Okay, I found this quote: "Every great story seems to begin with a snake." So I think maybe one of the reasons they put the first topic snake-related injury is because of this. Okay. All right. So my outlines will be some. A bit of introductions and a bit of snakes in the Malaysia, and we go to the common clinical effects of the snake venoms and how do you manage pre-hospitally and a bit of intra-hospital management for snake-related injury, and what are the common pitfalls that always occur in management of snake bites. Okay, so from the WHO guideline, which the second edition in 2016, it's mentioned that snake bite is actually a potentially life-threatening disease caused by the toxin released by the venomous snakes. And from data in the WHO guideline, it shows that about up to 5.4 million people get bitten globally about in a year. So from out of these 5.4 million, about half of it develop significant clinical illnesses. And unfortunately, up to 138,000 people died from complication of snake-related injuries. How about Malaysia? So from the CPG Management of Snake Bite published in 2017, from the year of 2010 to the year of 2014, roughly about 15,000 plus cases of snake bite. Okay. All right. And I think this data was presented by Dr. Reza Murad. Okay. I mean, one of the webinar snake-related injury during COVID era. So as you can see from 2018, 2019, and 2020, here's 2018, you see out of the 171 snake bite cases consulted in the REX group, 233 are venomous snake. So out of this, almost 40% of almost 50% are Naja species, which is Naja cotea and Naja sumatrana. Naja cotea being the highest number of cases, okay, followed by the Naja sumatrana and also Malayan pit viper and also king cobra. Okay. Similarly, in 2019, also Naja sumatrana still the highest number of snake bite, venomous snake bite, and it increases to 2020. This is up until September. So out of 696, 165 are venomous snakes. So a brief introduction about snake families in Malaysia. So there are I think about 14 families of snake. Okay, so out of it, total species are about 192. So the commonest, two commonest venomous snake that we usually encounter are from the Elapidae and Viperidae. Okay, although Phytanidae are not venomous, but they can also cause significant tissue injury or clinical injury, which is usually massive tissue, can cause massive tissue destruction, which need further debridement. Right? In the world, I think there are about 3,000 plus of species of snake throughout the world. Okay, if you want to know or you want to know more about snakes and get to know all the species, especially in Malaysia, you can refer to a few books and a few guidelines, especially the land snake of medical significance in Malaysia. Okay, our CPG guideline of management of snakes, and of these two books, okay, Snakes of Borneo and Snake of the Peninsula Malaysia and Singapore. Okay, all right. So we go into the clinical effects of the snake venom. Okay, generally we are concerned about either local envenomation or systemic envenomation. Okay, commonly there are four systemic manifestations, which is neurotoxic, hematotoxic, cardiotoxic, and myotoxic. Common presentation, we always get patient presented with ptosis and followed by muscle paralysis, especially respiratory muscle paralysis. Okay, hematotoxic commonly caused by the Viperidae. Okay, cardiotoxic patient can present with arrhythmia, hypotension, okay, tachycardia. And some snake, especially for example, sea snake, can cause a myotoxicity. For local effect, most commonly that we are concerned of is a cytotoxic. Patient will be having severe pain, okay, progressively move, swelling and edema, and also local tissue necrosis, either dermal necrosis, or they can have a blister or hemorrhagic bullae. Okay. So, as I said, the commonest venomous snake we encountered during rat consultation are cobra or Naja species. In Malaysia, we have two species, Naja sumatrana and Naja cautia. Okay, so they can present patient with bitten by a cobra snake. They can have a neurotoxic effect, paralysis. Okay, usually the earliest sign would be ptosis, and patient will start to complain of difficulty swallowing, difficulty to breathe. Okay, and it can be that patient can progress into cardiac arrest if the respiratory muscles are involved. Okay, and quite commonly we see a typical bite wound from Naja species, which produce a dermal necrosis. Sometimes it might be very faint, might be very not clear at the beginning, but somehow in a few hours and days, it become more prominent. Okay, and usually if the area is quite significant, it will be the secondary infection is possible to set in, and patient might require a surgical intervention. Okay, all right. This is a example of a patient bitten by Naja species. As you can see, at the 4 hours post bite, you can see a dermal necrosis over the dorsum aspect of the foot, and then at day 2, 48 hours later, the dermal necrosis expanded proximally. Okay, and it become more prominent, more demarcated, right? Then subsequently need a surgical debridement. Okay. Okay, another case of unidentified snake bite, but most likely from the Naja species, which occurred in Sabah. Okay, so at the beginning, you see, we could have missed, if we do not examine clearly, we could have missed the dermal necrosis, especially in the dark skin patient. Okay, so later on it progresses, right? And then you can see there are skip lesion as well, right? So after being given, the patient was given antivenom 5 hours post-bite. So, okay, right. Okay. The next group of LAPD is crepes. Okay, not as common as Naja, but it can also cause a neurotoxicity. Okay, so it affects a postsynaptic motor end plate. Okay, so can cause muscle paralysis. Usually, it cause minimal local pain or envenoming. Okay, and the third one is coral snake. Okay, coral snake. They potentially can cause muscle paralysis. Okay, so but the local effect usually quite minimal pain and minimal swelling, and some of them cause some degree of myotoxicity, and we need to monitor CK regularly. Okay, the third group is pit vipers or Viperidae. Okay, so in the northern part of Peninsular Malaysia, we commonly encounter a Malayan pit viper, okay, which can produce significant coagulopathy, okay, as early or later more than 48 hours after bite, okay, and in some cases it can be prolonged or rebound, okay, because of the depot effect and up to weeks, okay. Usually it may cause severe, it usually does cause severe pain and progressively worsening swelling. Okay. All right. So from this serial picture, you see after Malayan pit viper bite, sorry. Okay. Patient developed hemorrhagic blister, significant swelling, okay, which needed aspiration to release the swelling, and subsequently, of course, patient was given Malayan pit viper antivenom. Okay. All right. Sea snake is rarely encountered, but it can cause muscle paralysis, okay, myotoxic, and even rhabdomyolysis, causing as features by myoglobinuria.
I'm sorry, Dr.
Sorry.
There's something obstructing the view.
Oh, is it okay now?
The orange box.
Sorry, yeah. Okay. Orange box.
Doktor boleh unshare lepas tu share balik.
Baiklah, sekejap saya move ni dulu. I stop sharing first. Okay. Is it better now or still the same?
Ada box warna orange. Cuba unshare lepas tu share balik.
Okay.
Okay now, Doktor.
Okay, better. Alright.
Okay, better.
Okay, so sea snake is not commonly encountered, but it does occur. And we encountered one cases last year in Cebu, whereby a patient was referred from the Clinic Kesihatan Belawai, a 15-year-old, went for fishing and got bitten by a snake. And this was the actual snake that bit the patient. So patient presented with respiratory paralysis, needing intubation. So patient was given sea snake antivenom 1 vial and subsequently improved. So it can cause muscle paralysis, neurotoxicity, myotoxic, and rhabdomyolysis. So, however, usually the pain of the local pain is minimal. However, it can cause generalized muscle pain. Okay. Right. Apart from bite, we also encountered consultation regarding venom ophthalmia, which is sprayed. The venom was sprayed by the snake, namely Naja sumatrana, okay, into the patient's eyes. So it can occur up until 2 meters and from the snake. So patient will come with extreme pain, eye pain, eye redness, conjunctivitis with profuse eye discharge, and also blepharospasm. Okay, so for this patient, before you conclude that is venom ophthalmia, make sure that you rule out whether the patient has concurrent bite or not. Okay, so our initial management is, of course, we need to irrigate with copious amount of water, sometimes needing up to 5 to 10 liter, all right, until the pain subsides. And of course, need further assessment from the ophthalmology. Commonly, patient can have corneal injury, corneal ulceration. Okay, and just to note that for venom ophthalmia, topical steroid is contraindicated. Okay, and it can result in corneal melting. All right, and urgent ophthalmology referral is needed. Topical use of antivenom up to date is not recommended. Okay. Okay. Although python bite is not a venomous, python is not a venomous snake. So, but however, it does possess a significant tissue injury to the bitten area. Okay. For example, these fingers, you see multiple laceration wound, deep laceration wound. So, if we get such cases of python bite, do examine the wound carefully. Okay, assessment of the depth of the injury, and most likely, if the injury is very deep, the wound is very big enough, we need to proceed with X-ray to rule out foreign body, teeth, okay, and even a fracture. Okay, and of course, as per wound animal bite management, patient have to be referred for the wound debridement. Okay, all right. So, what are the initial management of snake-related injury or snake bite? Pre-hospitally, most importantly, we need to, if you happen to be at the pre-hospital site, calm the patient down, okay, reduce the movement, or if you could immobilize, then you immobilize the affected limb. And of course, you want the patient to be brought to the hospitals. Better still if the hospital can provide anti-venom therapy, right? Or at least emergency department. Okay, so the don'ts, these are very interesting part when dealing with snake bite. You see a lot of myth and a lot of the don'ts being done to the patient. Okay, do not bring the patient to the BOMO. Sometimes the relative brought the snake bite patient to BOMO instead of to the hospital, right? We see still some suck the wound, cut the wound, even tourniquet or tie the wound, okay, massage over the wound, okay, apply ice, even burn, and of course in Sarawak we see quite a number of patients still apply some traditional remedies. Even they kill the snake, they take the snake's blood and apply onto the wound. Okay. Again, in reality, okay, patients still believe in some ubat anti-racun, okay, and they apply some traditional ointment, kunyit, etc. Okay, and this is also an important pre-hospital care. If let's say patient can already kill the snake, it is very useful if patient can at least bring the snake or even take a photo of the snake for identification. Okay, and of course, some of them still believe in tying or tourniquet the limb to so-called prevent the movement of the venom. Okay, this is our real case. Okay, patient did a double measures, did a cross incision, and we believe patient also did a suction, some sort of suctioning, okay, using maybe cupping device. Okay. All right. Another unlucky guy in Sabah, bitten by a king cobra. So he tied, not just he tied multiple level of tourniquet onto his left upper limb, he also tied the the snake. Okay. So unfortunately, this guy developed neurotoxicity and he lost his limb. Okay. Okay. Before taking patient to the hospital, it will be very useful if we can immobilize the bitten part. So we reduce the movement and reduce the muscle movement of the bitten part. Okay. Okay. Another method, useful method to use in the snake bite patient is pressure bandage immobilization. Okay. This usually sometime in the hospitals or pre-hospital we use elastic bandage, not the normal bandage that you use, but the elastic one. Okay. Okay. Why it is advocate is because we believe that some sort of pressure we compress the lymphatic vessel at the bite by bandaging. Okay, so we extend upwards along as much of the bitten limb as possible. Okay, so we immobilize to slow and to stop the movement of limb in the vessels. Okay, by putting a splint and keeping the patient still. Okay, splinting restrict the pumping effect of the muscle movement. Okay. All right. So when is it useful? Okay, for PBI. So we can apply that in if you suspect a neurotoxic elapids, okay, or if you are from very remote area, very far away from hospital, prolonged transport time, we can use the PBI, right? When we should not apply it, okay, we should not apply it in the pit viper or patient with significant cytotoxic. Okay, it may worsen the cytotoxic effect of the snake bite. Okay. Okay. When do we release it? So when the patient arrives in hospital, when you are already at the emergency department where resuscitation is available, and you have the antivenom on standby. Okay. All right. However, do not forget, apart from the pre-hospital measure, you need a good history. We need good history to help us in managing snake-related injury. So in CPG, we already outlined what are the details that needed. Okay, we want to know the precisely when was the patient bitten. Okay, how is the progression of the sign and symptom, and geolocation or address of the patient would be really helpful because we can determine the possible potential indigenous snake in the region, okay, so that we can tally our antivenom accordingly. Okay, from the, I think some of the experts, they can tell from the behavior of the snake, how the patient, what are the activity of the patient when getting bitten, and how the patient describe the snake. Okay, if possible, we are very happy if the patient can provide to us the picture or even a video, or if patient can identify from our gallery. Okay, where part of the body bitten, you need to identify. Okay, and then what was done, because this sometimes can manipulation of the bitten part sometimes can affect of can give effect of worsening swelling, worsening bleeding, and skin changes. Okay, what are the treatment given? Okay, and last but not least, anaphylaxis risk. If the patient is already, being bitten before and regularly play or snake charmer, snake keeper, they has the tendency to get allergic reaction. Okay, if you consulted Rex many times, you are familiar with the, I would say, famous box. We need all these locations, all this information and details. Okay. All right. So after getting a good history, the next step is monitoring. Because from history, from monitoring, okay, from examination, we help the clinician to decide whether this patient need antivenom therapy or not. Okay. So the important part of monitoring are the rate of proximal progression, RPP, pain score progression, and any skin changes, especially the monocosis, which is a typical Naja species bite, and any sign of this systemic envenomation. And we also send for or do serial blood investigation, commonly full blood count, CK, and coagulation profile. This is an example of the snake bite suggested by the guidelines. Okay, we monitor the vital sign and includes the PSP, RPP. Mind you, the RPP is actually centimeter per hour. It's not just merely a distance. Okay, and talking about RPP, it's not just about the number. We are monitoring the trend, whether is it accelerating, is it static, or is it decelerating. Okay, correlating with the pain and any tender lymph nodes. Okay, and very useful if you could tabulate your result into the chart. Okay, so that we can monitor the trend. Again, some always query why the patient already deranged INR, we did not start antivenom. Okay, so actually we are monitoring monitoring the trend, not just a single reading, and have to monitor also the other parameters. Okay, all right. So this is an example of RPP being done to a patient bitten by king cobra. Okay, but it would be good if we could remove all the distal markings and just keep the most proximal one. Okay, okay. Just exactly how do you measure? I think this has been taught in the consultation group before. Okay, you take the distal border up to distal border and you divide onto the hours of the monitoring. Okay, all right. Just to remind or to advise some of the frontliners, sometimes we tend to mark or draw using marker, using all sort of ink onto the bitten area. Some even draw, I don't know what shape is that. Okay, so this actually not recommended, as it might mask or obscure our view, especially if any presence of the monocosis. Okay. If still in doubt, how you are not sure whether the swelling has progressed, whether the swelling is increasing, we can get consider the use of ultrasound to demarcate or locate the extension of the swelling. Okay. Right. For investigation, depend on the type of the snake bite. So we commonly monitor FBC, coag. For pit viper, usually we monitor 6 hourly. Okay, and then we taper down according to the clinical conditions. CK, and then we need to have a renal function or liver function test. Okay, sometimes patient might have pre-existing thrombocytopenia because of the chronic liver injury. Okay, and depending on the clinical status, we also send for the D-dimer and fibrinogen level occasionally. All right. So after we got the history, after we monitor the patient, so now we must decide whether antivenom is needed or not. Okay. So in the guideline, of course, we monitor the indications are either systemic or local envenoming. Okay. For Naja species, usually if patient presented with systemic envenoming, we usually start at least 5 to 10 vials. For local, usually we start 5 vials. And for pit vipers, okay, or Malayan pit vipers, we usually start 3 vials and then we top up accordingly. All right. So just a bit of antivenom administration. It is, for now, it's just IV route only. There's no IM administration of antivenom, sublingual or etc. Okay. And some would wonder whether local inoculation is effective. As for now, it's not effective. And then ideally, antivenom should be diluted and given as infusion, not a rapid bolus. Okay. All right. I'm sure you have encountered, you have gone through this preparation and administration. Okay. Some important part, you need to avoid shaking the vials. Okay. Just gently swirl to dissolve the freeze-dried antivenom. And this, whether it's adult or child, you need to further dilute. For child, you need to dilute. It's either 5 to 10 ml per kg, or in adult for 250 or 5 ml normal saline or dextrose 5. Okay. You might want to stand by adrenaline in case patient develop anaphylaxis. Okay, and then you start the antivenom slowly at the beginning 1 to 2 ml per minute for 5 to 10 minutes, then subsequently increase 5 to 10 ml per minute, trying to complete within 1 hour. Okay, all right. There are no contraindication for antivenom in the event of any envenoming so far. Right. Okay. Then the next question will be, should we repeat? So the decision to repeat, you need to monitor closely, monitor the response or monitor the recurrent envenomation. Okay. For hematotoxic, okay, you monitor whether any more spontaneous bleeding. Okay. If not, you just repeat your coact and FBC in 6 hours. Okay. For neuro and cardiotoxicity, you reassess immediately, clinically. Usually they can respond up to as early as 30 minutes, okay, and continue close monitoring. And for myotoxicity, you monitor the CK level. All right. So as I said, the response, the patient has asked the patient whether does he or she feel better, and then monitor the systemic manifestation, the blood parameters, and also the other clinical symptom and sign. Okay. What are the common pitfalls in managing snake-related injury? Number one, routine use of steroid and antihistamines. This has been encountered so many times, okay, especially at the primary care level. Okay, and if steroid and antihistamine should not be given without any clear indication. And furthermore, some of the antihistamine does produce a sedative effect, which might disturb or mislead your assessment later. And as I said earlier, rarely patient get anaphylaxis in after following the snake bite. Okay. Number two, we did not examine the local part carefully. Okay, sometimes small skin changes or dermonecrosis might be missed. Okay, so if we able to pick up the local tissue or local dermonecrosis, we might alert, or we might be standbying the antivenom early and administer it promptly. Okay. Pitfall number 3, overdiagnosing compartment syndrome. This usually, I think over the years, I think since I joined REC, the incidence has been reducing as compared to years before, whereby all the snake bite, the first thing they will think is compartment syndrome. Okay, we all know that compartment syndrome can produce hypoesthesia, okay, as a result of the nerve being compressed, the pain very out proportion of the injury, pain on passive stretch, very tense compartment on palpation, and sometimes quite late patient presented with weakness. Okay. However, in snake bite envenoming, it's actually not of a compartment syndrome per se. It's actually envenoming syndrome. Okay. Usually the hypoesthesia is absent, but the pain surely will be presented. Okay, because of the cytotoxic venom effect. Okay. And pain on the passive stretch is also attributed to the cytotoxic venom effect. And the tense or the gross swelling is usually due to soft tissue and muscle edema. Okay. And weakness of the involved muscles. Okay. Because usually it's not because of the compartment per se, but more or less because of the pain, limited movement, because of the pain and swelling. So in general, fasciotomy is not indicated, and we should be considering antivenom. Okay. Another pitfalls, transfusing blood products in envenomation-induced coagulopathy. Okay. Of course, and if you are bitten by especially Malayan pit viper or some green pit viper, you might get deranged coagulation profile or even bleeding. Okay. So however, it's good to stress out that blood products are not the substitute for antivenom. You should not be thinking of blood product as a first line. Okay, we must be thinking of antivenom. Okay, it's just in case the patient develops severe bleeding where you are not in the center which possess antivenom, then only you might consider to monitor to give your blood products. Okay, and to add on, tranexamic acid, okay, antifibrinolytic and vitamin K are not effective too in managing snake bite induced coagulopathy. Okay, all right. Just remember this: not all snake bite cases need blood. Not all snake bite cases even need a IV cannula. Majority of the snake bite we encountered mostly from the non-venomous snake. Okay, so just not to put as a knee-jerk reflex where all snake bite you must send for all full package of blood investigation. Okay, then not all snake bite cases need admission. Okay, if you are able to identify the snake, you are able to examine the patient, identify the snake, confirm it's not venomous, then you can safely discharge the patient. Okay, and also we encounter several cases which not needing actually to be transferred to tertiary center, but because of the patient potentially need antivenom, okay, even though the hospitals already have antivenom, they still transfer the patient to the tertiary center. Okay, this sometimes can be avoided, and the antivenom actually can be safely administered in the hospitals, the initial hospital itself. Okay, and not all snakebite cases, or even though require antivenom, need ICU admission. Okay, we can reserve that for a better indication. Okay, and of course, if any doubt, free to consult. Okay, we have long list, I think about 60 plus REX group, okay, nationwide. And for those of you who are not aware what is REX, REX is usually a group, remote envenomation consultation services, comprises of consultants who are readily 24 hours on call, 24 hours on call consultation, okay, since 2012, okay. And soon we are moving towards an app called MyRex. Okay, now we are in the stage of testing the usage. So soon we'll be moving towards apps consultation for snakebite cases. All right. So I think with that, I end my presentation. Thank you.
Okay, thank you, Dr. Anas, for a very informative presentations. And then I'm Hafiq, one of the moderator today. So before I'm starting with the second speaker for today, I just was to introduce, to remind back for those who are just joined us for today. And for the Zoom participant is already full. Who would like to join our discussion? There will be a link for Facebook Live in the chat box. And then for questions to our speakers, please type in the Q&A box, not the chat box. And then the e-certificate will be sent via email after filling in the feedback form at the end of the webinar. And then the QR code for scanning for MMA CPD point will be displayed at the end of the webinar. And last thing, the webinar can be viewed by the live stream on the Facebook page of CPC Faculty of Medicine UKM.
Okay, next up. Okay, next up, we have Prof. Sataria from Bangkok, Thailand. Prof. Sataria, can you hear me?
Yes.
Sawadee krap.
สวัสดีค่ะ
Yeah, good morning. She's okay. Prof. Sataria has a rather colorful CV. She's a specialist besides in emergency medicine. She also has or is a specialist in internal medicine, in clinical pharmacology and in clinical toxicology. And her areas of interest, of special interest, are heavy metals, pesticides, natural toxins, and especially the plant kratom, or in Malaysia, where we're airing from, it's locally known as kertom. Okay, so she will be giving us some insight today on plants and herbal poison. Take it away, Prof.
Okay, can you hear me clearly? Okay, good morning, everyone. And first, I would like to thank the organizing committee for inviting me to be a speaker in this conference. It's my honor to be here. And today I will talk about plants and herbal poisoning. And I have no conflicts of interest, and the references for all details or pictures are cited for each slide. And my outlines of my talk will cover the common plant and herbal poisoning in Asia, including the type, mechanism of toxicity, the clinical manifestations, which are mainly based on the target organs of toxicity, the management. I will not include the plants for recreational purposes like cannabis and plants of drug interaction. First, I will begin with the classifications of plant xenobiotics. There are mainly 5 major groups, including like alkaloid, glycoside, terpenes, proteins, and phenols. And plants are quite variable based on like potency and type of xenobiotics, depending on many factors like seasons or method of processing. If you can identify the plant species or communicate with the botanist or toxicologist or the poisons control center, they might help manage the poisons patients with plant poisoning. But however, most patients will be receive the supportive care, which are the main treatment for plant and herbal poisoning for most cases. And I try to find the publications about plant poisoning in Asia, and this is the one that from our poison center, that poisoning in Thailand corrected for 10 years. And from our data, we found that Jatropha carcass is the most common cause of plant poisoning in our country, while cassava is the most common cause of death. And if you see, we have about 400 to 600 each year for cases of plant poisoning, varying by month. And cassava causes the high mortality, like about 4%, while Nag vomica that causes spinal seizure has about 9% for mortality rate. That is quite high, but we have only 11 cases for a total. So I will describe the plants and herbal poisoning based on the target organs of the toxicity, and I will give you the example of poisonous plants, like the famous one. And the first organ is the skin, cutaneous, and mucosa. There are 4 main mechanisms to cause skin toxicity from plants. Mechanical injury, irritants, allergy, photosensitivity, and all these cause clinical effects of irritations, right? Dermal or eye irritations. And the management includes decontaminations as indicated, and supportive and symptomatic care are the main treatment also. For the first mechanism, the mechanical injury, you might hear about like stinging nettle that contain apparatus to deliver the irritant chemical. And so when the patients contact with the stinging hair, it produces micromechanical injury and release the irritant contents that cause skin irritations. The example of the plants which cause these is Lapotia interrupta in family Urticaceae, or the common name hen's nettle, and the toxic part is the hairy part that contain toxin. Or Mucuna pruriens in family Leguminosae, the common name with Colwich. And the other plants that cause mechanical injury, it caused from the painful microtoma that produced by the needle-like calcium oxalate crystal that called laphides, like in elephant ear or dumb cane. I will show you the picture. This is a picture of Diephenbachia seguins in family Alaceae, or the common name as dumb cane, that contain the calcium oxalate crystal. And this is the report of crystallized keratopathy from Diephenbachia sap, that the crystal will be stick on the patient's cornea, and it resolve spontaneously after 3 months. And this is the real case from our poison center. The patient cut the bush and the sap squirt into his eye, and you can see that the crystal is in his cornea, like this, you can see. And the other plant that causes skin irritations from calcium oxalate crystal is Caladium bicolor in the same family, Alaceae. The next mechanism for skin injury is irritant dermatitis from the xenobiotic that penetrates skin, like diterpene ester. These plants, Euphorbia tilucali in family Euphorbiaceae, or the common name pencil pants or millbush, or this Euphorbia antiquorum Malayan spur tree in the same family from the latex that contain toxin. The next mechanism is allergic contact dermatitis from type 4 hypersensitivity. So the patients require prior exposures to the agents before the symptom occur. The famous one is ullucinol resins that derive from the catechol found in many families of the plants. The famous one is the pistachio or cashew nuts that you might know it. The first one is cashew nut tree, Anacardium occidentale in family, Anacardiaceae, or cashew nut tree. This is show the case report of skin reactions, both immediate and delayed from contact with cashew seed shell. So it causes allergic contact dermatitis. Like for the first exposure, ullucinol resins penetrate the skin and react to form the antigen. And when the patients re-expose, the inflammatory mediator are released and cause the skin effects. Like and in severe case, it can progress to the type 1 hypersensitivity. And this is the real case, our case from Poison Center, that the patients remove the shell and ate the cashew nut. And after that, she felt burning sensations and developed mucositis at her mouth, throat, and vaginitis and proctitis. You can see that she has diffuse lash and have vaginitis and proctitis. And allergic contact dermatitis is also the most common plant-induced occupational injury, like reactions report from exposure to tulip, like in the worker who chronically handle the tulip, like in the flower shops, like that, and it causes allergic dermatitis. And the last mechanism for skin is photosensitivity, right? The compound contact with the kins or digest into the bloodborne and interact with the sunlight and cause severe sunburn-like symptoms, and hyperpigment will last for several months. And these compounds are found in many plant species, including like food sources like carrot, grapefruit, lemon, like that. Okay, and the other plants that might cause skin irritations is capsaicin, that is compound from chili or pepper, and it releases substance P. So when the patients contact, they might have burning sensations or pain and irritations. The next system is GI tract. The main toxins include calcium oxalates, triterpene ester, tocalbumin, and anthraquinone glycoside. These all cause GI effects like nausea, vomiting, diarrhea, salivations, drooling, and the main management are the same, like decontaminations as indicated and supportive care. The first toxin is calcium oxalate, which is insoluble, found in like elephant ear, dumb cane, Japanese taro. And when the patient ingests this plant, they will have the immediate pain and swelling and can progress to dysphagia. It can cause upper airway obstruction in the severe cases. And for ocular exposure, it causes like conjunctivitis or abrasions. And treatment include the supportive care. Some might prescribe opioids, steroids in severe case. And you have to concern about airway protections if the patients develop airway compromise or upper airway obstruction. This is the example of the plant Damcane, that if the patient's contact by skin, it causes skin irritations. But if the patients ingest it will cause GI irritations and especially upper tract. And one of our dead cases in our study, hand poisoning, one died from ingestions of latex of euphobia and developed hemorrhagic gastroenteritis and shock. And in the surgery, it revealed gangrene of the bowel. So it can cause death in some severe cases. The other crystal like oxalate lapha that contain in the household plant in the same family, it can cause skin GI irritations, but not as painful as the Damcane by other reasons or factor. This is from the news that is quite common in Thailand, that because this is the plant that it is eatable and it is cooked for the curry, we have to eat this curry. But sometimes the chef or the cooker misunderstand that this plant which is uneatable is the eatable one. So they use this plant to cook as the curry, and sometimes the patients ate this uneatable plant. And this uneatable plant contains calcium oxalate crystal that you can see, and it will hurt the GI tract of the patients. And you can see that calcium oxalate crystal also found in other plants. So the next toxin is toxalbumin. The toxalbumin found in like Jatropha carcass in family Euphorbiaceae. The patients will eat the seeds, and Jatropha carcass of physic nut is commonly grown in and planted in Thailand because of the biodiesel industry. So it's used for biodiesel. So it is the most common one in Thailand that cause pan poisoning. It's quite common. And another is like Jatropha gossyphilia in the same family, multifida in the same family, and the seeds contain the hyaline and crepitin. And it's called GI effect like diarrhea, nausea, vomiting, similar to like croton oil plant at the seed. The last toxin is anthraquinone glycoside, or you can as like senoside. Is used as laxative or sometimes antibiotic. It metabolize in our body and stimulate the chronic mortality and accumulate water and electrolyte in the gut rumen and cause GI effect, especially diarrhea. And it found in the cassia or senna species, right? Senna cymea. The next system is neurologic system. I will begin with the spinal cord. The plant that causes spinal seizures by blocking the binding of glycines or inhibitory neurotransmitter in the spinal cord is strychnine vomica that contains strychnine or strychnine and brucine. And it causes spinal seizure. The patients will seize, but they will awake or have the conscious during seizing. And so the management, besides supportive and symptomatic care, you have to stop seizing by using many drugs like benzodiazepine, barbiturates, and treat the complications from seizing, such as rhabdomyolysis and hyperthermia. This is the picture of strychnine vomica in the seed contains strychnine and strychnine. The cure is from the bark of Crododendron tomentosum that contains the tibocuralin chloride. It's an antagonist of acetylcholine at nicotinic receptor in MJ. It's the plant that causes neurologic toxicity. And the other one is Dioscorea hispida, or that contain Dioscorean. It causes dizziness, alterations of consciousness, and sometimes in severe case like paralysis. And the management include like supportive care. This is the picture that you might be know this plant. It's called YM for the common name, and is the family the Dioscolaceae. Is the yam contain dioscoline, and after the proper process, the dioscoline will be less, and we can eat. And another one is the star fruit. It's quite well-known fruit in our country and our region. Our calambola in the family, our CE. If the patient has the chronic kidney disease and ingest this fruit, it can cause like neurotoxicity, like hiccup, confusion, seizure from calamboxin, and it can cause acute oxalate nephropathy also. So management includes supportive care and hemodialysis, especially for the severe case. And the plant also causes stimulants and depressant. One is the quite well-known one is Ephrida, that is used as the Chinese herbal medicines. It's the member of genus Ephrida. It's used as stimulant because it contains ephedrine and pseudoephedrine. So it can cause symptomimetic toxidrome like hypertension, palpitations, anxiety, restless, psychosis, and arrhythmia. Other plants include like the cathinone. And true thorn or wormwood plant, I think that is not common in our country, but it's in the traditional medicines, and it's the main ingredient in absinthe liqueur that you might hear about this liqueur. And it works as similar to camphor and producing as depressions and seizure, and in chronic use, it can cause absenteeisms like seizure, hallucinations, or personality changes, like this. The next organ is anticholinergic toxidrome by competitive antagonist of acetylcholine. The famous one is Datura species, especially Jimson wheat seeds. In family Solanaceae that contain belladonna alkaloid. So the patients will present with anticholinergic toxidrome like tachycardia, hyperthermia, dry skin. The onset is quite very early, and the management is supportive care mainly, but physostigmine may be reserved for the severe cases. Like this, the picture of Datura or apple or pelu, and contain high-ocene scopolamine that has the anticholinergic effects. And the betel nut, chewing for euphoric or used as herb, it has the alicholine that work as nicotinic agonist, and if the patients ingest a lot, it can cause like sweating, salivations, and hyperthermia. And other plants also contain like nicotine and nicotine-like alkaloid like codeine, nicotines, or other plants. And the next system is cardiovascular system. The plant that causes cardiovascular toxicity divide widely to two groups, like cardioactive steroid, that is cardiac glycoside plants, and the plant that affects the sodium channel like aconitin or taxine. I will begin with cardioactive steroid, or the plant that contains cardiac glycoside. It works as digitalis-like effect, so it blocks sodium K-ATPase, and then has the acute digoxins, similar to acute digoxin toxicity, right? GI symptom, arrhythmia, both body or when tachyarrhythmia, heart block, neurologic symptom, and especially the hyperkalemia. The treatment of these plants follow the acute digoxin poisoning management the same, and the antidote is reserved for the severe case like life-threatening arrhythmia. And in one standard textbook, they recommend the antidote for poisoning with a non-digoxin cardioactive steroid that might include these plants also. And so you have to think about it in the severe cases. This is the picture of the yellow oriander that contain cardiac glycoside. And very interesting that in the study from Sri Lanka, the acute yellow oriander poisoning in 51 patients, you can see that most patients had bradycardia and heart block, and only few patients develop ventricular VT or VF. So it follow acute digoxin poisoning that bradyarrhythmia might be commonly found. The other plants that contain cardiac glycoside include rice, sweet, oriander, foxglove, that you might know these plants, impala lily in cloudflower, and Erythrophyums in family Fabaceae, and Cerbera odorum in family Apocynaceae. Some last month, one patient accidental ingest. She is the foreigner because she concerned that she misunderstood that it is the orange and ingest it, and some use it for suicide attempts in our country. The next one is aconitum. Aconitum is a aconite that from roots or plant from genus Aconitum that is commonly used as Chinese herbal medicine. It contains aconitine that binds to the sodium channel in heart and nervous system and increase and prolong sodium influx. So it causes neurotoxicity, arrhythmia, and very hypotension, and can cause death also. So management include the supportive care. So I will go to the next, multi-system organ. That the first one that causes multi-organ failure by histotoxic mechanism, cyanogenic glycoside, that you might be quite familiar to this plant, like cassava that contain ribamylin and amygdalin in the fruit, like the peaches, leisurely in the seeds. So it will be changed in our body, and cyanide will be released in our body, and it can cause cyanide poisoning, like altered mental status, seizure, collapse, acidosis, the same as cyanide poisoning, but because it is metabolized in our body, so it will take time to for the onset of the cyanide poisoning. And this cyanogenic glycoside also found in the flower like hydrangea. So this is the picture of cassava that contain ribamylin that can cause cyanide poisoning, and we use the cyanide antidotes like sodium nitrite and sodium thiosulfate or hydroxycobalamin for the severe cases. And the other plant that cause histotoxic mechanism and cause multi-organ failure is the yam bean that contain rotenone. It causes decreased consciousness, acidosis, and multi-organ failure. Like we call the yam bean that contain rotenone, and the toxic part is the seeds and the leaves, and you can eat this. And the next one for multi-organ failure from cellular arrest, that from rosary pea and castor bean. So it causes like GI, renal, liver failure, and like this rosary pea that contain the outabrin, and castor oil that you might hear about it contain lysine and cause multi-organ failure. And this is the quite famous in our country, Gloriosa superba in family Colchiaceae, that the root contain methylcolchicine. So if the patients ingest this as sometimes they use as herb, the patients will develop like colchicine poisoning, follow the face like colchicine poisoning, and other plant that contain antimycotic alkaloid, like besides colchicine, like vincristine and podophyllum, are also from the plants. The next one is the kidney. Kidney, I think that you might know this, is called luk niang in Thai, and is ginkgo bean fruit that contain ginkgolic acid in family Leguminosae. And because it's not uncommon in Thailand. We have protocol treatment for our poison center. And you know that if the patients ingest, in some patients develop the toxicity, that the mechanism might be from ATN, hypersensitivity, crystal obstructions. The patients will present with like frank pain, body cloudy, urine and anuria, hypertension or AKI, and we will recommend hydrations, supportive care, sodium bicarb, and hemodialysis in the severe cases. And is this from the real case that you can see the crystal in the patient's urine, bloody and cloudy urine also. The next one is allistolochic acid that is in the Allistolochia genus that is used as herbal remedy. It causes nephropathy and cancer. And this is the picture of bilimbi or cucumber tree that has the high content of oxalic crystal, oxalic acid, and it can cause nephrotoxicity from calcium oxalate crystal you can see in the urine. And these are the risks of Chinese herbal medicines that are known or associated with nephrotoxicity. The next one is hematologic system. Acalypha indica in family Euphorbiaceae. In Thailand, some use as the herbal remedies. And from the recent publications from our poison center about Acalypha indica poisoning, it caused acute hemolysis and methemoglobinemia. And the proposed substance that cause these hemolysis and methemoglobinemia include like quinines and antaquinone that is in Acalypha indica. And favism, after eating fava bean in G6PD, it can cause hemolytic crisis. And ginkgo lies in ginkgo biloba that can result in antiplatelet aggregations and cause bleeding. The next one is the liver. From our hospital, we published one case, the child ingested Cassia occidentalis and developed acute liver failure that from Senna occidentalis. And pyroridine alkaloid that is in many plant families and is used as in the herbal remedy is in Thailand we also have, and it can cause hepatic veno-occlusive disease from the metabolite that called pyro. And Senna-Cymia, that the leaf is used in for cooking as the curry, or some use as the herbal medicine in the capsule. And this can cause hepatitis in some patients. And these are the list of the supplement product discussed in the Liver Talk website about the cause of the liver toxicity. You see a lot that the supplement. And the last one is the metabolic effects from the plants. The first one is licorice. You might know licorice. It inhibits enzyme that converts cortisol to cortisone, and it causes pseudo hyperaldosteronism. The patients might present with muscle weakness, hypokalemia, hypertension, and arrhythmia. The other one is hypoglycin A and hypoglycin B found in unripe fruit and seeds of the active fruit. And it can cause like Jamaican vomiting sickness. And hypoglycin A, when it's metabolized in the body, inhibits various enzymes and glutamic acid decarboxylase, and can cause like CNS effect like convulsions. And recent the publications in India, it caused like acute toxic encephalopathy, like hypoglycemia and metabolic derangement from active fruit also. So in conclusions, poisoning following plants and herbal medicines in our regions is not uncommon, especially in my country. And the onset of the symptom could be immediate or delayed, depending on the type of the plants. The symptoms range from no, mild to severe, and some can cause death. And supportive and symptomatic care are the main treatment for this type of poisoning. However, some patients require the specific antidotes such as cyanogenic glycoside in cassava. So you have to like concern about the treat with specific treatment like antidotes in some cases. So that's all for my talk. Thank you very much for your attention and welcome to all questions.
Thank you very much, Prof. Satya. ขอบพระคุณครับ
สวัสดีค่ะ ขอบคุณมากค่ะ
Okay, all right. Thank you. Very in-depth and informative talk. Okay, so back to we're going to be taking a break now. Before we let the two other speakers talk on their topics, on their respective topics. So I'm going to give a reminder regarding the housekeeping rules again. For just a quick announcement regarding one of our collaborators. I think I didn't specifically state in the beginning who was involved in the organization of this program. This is the third emergency medicine seminar series organized by Hospital Chancellor Tuanku Muhriz or Hospital UKM here in Malaysia. We are the secretariat and we are airing from Kuala Lumpur, Malaysia. And the co-organizers are the University of Medicine Philippines and also Universitas Brawijaya in Indonesia. And we're doing this in collaboration with a few other organizations, namely RECS, Remote Envenomation Consultancy Services, ASEAN. Also, Malaysian Society of Toxicology, MST, and the Malaysian Society of Toxicology, MySoT. And here is one of the MySoT's programs, upcoming programs, the 11th Congress of Toxicology in Developing Countries, or CTDC 2021. It will be held from the 13th to 16th of June this year. And if you're interested, next page. You can see there. You can see here the panel of speakers which will be involved in the program. And if you're interested in joining, you can scan the QR code or go to the registration link as displayed. Okay. It's already 10 o'clock, so we are on time, and it's time to go to our third speaker. Have the floor, Dr. Vanessa. Are you here? It's already 10 o'clock, so we are on time, and it's time to go. Dr. Vanessa.
Yes, I'm here.
Okay, Dr. Vanessa, you have to. Excuse my Vietnamese. I literally learned it over the past weekend. Xin chào. Did I get that right?
Yes.
Okay. All right. Okay. Pleasure to have you here with us today. Dr. Vanessa is from Ho Chi Minh City. She's an attending physician at Chore Hospital and also a guest clinical lecturer at the University of Pharmacy and Medicine in Ho Chi Minh City. She has a special interest in chronic poisoning and unusual poisoning. And today she's here to enlighten us on mushroom and other organism toxin poisoning. So Dr. Vanessa, over to you.
So, hello everyone. Can you hear me well?
Loud and clear.
Okay. So my topic today, I talk about a mushroom and other organism toxin poisoning. So, what I can say now, because so I think is most of you know many things about mushroom and many natural toxin, right? So I think And especially in previous lecture from Thailand, I feel I am interested in your lecture a lot because you talk about many herbal medicine, but it's from plants. So many toxic plants, and I think, and I see that some of them look like we can use them to decorate in our house, right, or in our garden. It's because it's nice plant, but it is toxic. So for today, what I want to share you here is from Vietnam. I would like to share about something real when I met the patient in my hospital in Vietnam. So you can understand more about what happened in Vietnam. So I think maybe some of you read my publication is here. So today this is related to the mushroom. So I think I should want to say something about it, something different. So at first, when we receive some patient, so they have a sign of symptom, like in the table, you see they have a vomit, dizzy, and they have a salivation, myalgias, and some of patient, if they have a severe condition, so they have jaw stiffness. And also, some of them, they have a seizure and tremor, agitated delirium. Some of them, they have a hallucination, somnolence, and even more severe, they have a coma. So they told me that they eat the cicadanin. Yeah. So when we heard about the cicadanin, so okay, so after they eat the cicadanin, they fry cicadanin and they ate it. And then after 30 minutes, so they have those signs, symptoms, and they admit to the hospital. So so at that time, at first, for the first thinking about it in the emergency department, so I think most of physicians in ER, so they will think that so cicadanin poisoning. So is that true? So what happened? So cicadanin is not toxic. So why our patient have a poisoning? And when I met them, so they show me what they ate. So you see the picture on the slide. So that's it. They told me, so they ate that one. That is cicadanin. So how do you feel it? So we need to think about, so it's something weird, right? So this is cicadanin. It's the appearance, it looks like cicadanin, but something weird, it's something different. So in the countryside in Vietnam, the fried cicadanin in very interesting dishes. So many people who live in the countryside, they like to eat this dish, and they say it's delicious. So they ate cicadanin so many times, so nothing happened. But why this time they have those signs, symptoms? So that is the question, right? So in not only one case, but every time, every year, about I remember about around April to June and July, so we receive some case, something like that admit to our hospital. So you see on the map, so we have many places, so that's the patient stay there and they get the poison and they transfer to my hospital. And with the history after they ate cicadanin. So and how about the diagnosis for this case? Is it real for the cicadanin poisoning? So I think that if we check our patient about the laboratory blood test, so I think so we cannot say anything from the test. right? Because everything is normal, the blood state is normal. So it doesn't help for diagnosis. Doesn't tell you what happened or what the toxin inside. Yeah. But the sign symptom manifestation, you see that look like those the sign symptom here is affect to the neurotoxicity, right? So if, and also some patient, they have increased salivation, sweating, and some word treat with atropine because a bit more salivation. So I think we need to add the atropine to treat them, so to control them. And some severe case, they have a stiff jaw. They couldn't open their mouth to talk or to draw something. Yeah, they cannot do that. They cannot speak to you, cannot open the mouth. So I think so those case, so for clinical sign symptom, so just give you some ideas. So what kind of toxin? So that is toxin for like neurotoxin. But for the blood state, nothing to say. Yeah, that's nothing to say you anything about that. So if I do more, so this is so far I have my way for working to find the diagnosis. That's it, individual toxic agent screening by lead method. So that means I need to look like my question and everything. So I need to look like I live with the patient, I eat with the patient, work with the patient together. So why? Because I need to understand what happened to them, so I can find the conflict toxin. Yeah. So after that, I asked them and they showed me many things, and even I went to their country. I went to their hometown to see what happened to them and where they take it, how they make it. So, and then after that, I exclude the Cicadaneem poisoning. So the exact diagnosis, that is a fungus. That is one type of mushroom, or we can say the fungus. That is a cordyceps fungus poisoning. So what happened to them? So it is a story behind that. So as you know, in Vietnam, in the countryside, Cicadaneem, they live on the tongue, and after that, on the early period, so they will live in the soil, right? But and after many years, they can land on the tongue and they become the cicada. We become a cicada. So in the picture, you can see here in the picture, so let's see the Cicadaneem, they nearly become the real cicada. So if you want to eat the Cicadaneem, so you see the people, they will catch them on the tree at night, and they use the line to catch them. So that is a normal. So if you want to test the real cicada, the live Cicadaneem, so you need to do that. But you see that, in our case, the patient show me this kind of Cicadaneem they ate. It's different from the previous picture, right? So this is something here. So they have like the tail here on the head, many tail, something like this. So it's actually different. So when I came to their hometown to take it, and they show me it in the garden, in the mango garden. So they told me that it's in the soil. So they can take it from the soil and in the morning. And they have a lot everywhere in the garden, so you can take it. So this is when I went there. So this is the picture I took when my team and with my professor we went there. So you see, let's see the appearance of the Cicadaneem body, right? And so they have a fungus here. So I would like to show you on the YouTube, so a little bit, so you can understand more the real sense.
Mình dùng đúng mẫu váy trong buổi diễn năm ngoái đi, rồi váy tiền chẳng bao giờ thì bạc màu ASEAN cũng vậy. Vì tiền dùng công phong.
Hi, chào tất cả các bạn đã quay trở lại với Đi Rừng Làm Nãy nha. Đây là cây nấm gì?
So you
Nếu bạn nào
see,
biết có thể bình luận ở dưới. Một con phải không?
Sorry, Dr. Vanessa,
And-
we can't see your screen.
so you see here, so
Đây-
my patient,
Đây
you
có
see,
đây một con ve sầu nữa là
they did
Nó
the
là-
same in the
Đó là mình
video.
cứu
So you see something like
con
that
ve
in
sầu
the
nó
garden.
tay
You can find it in the soil.
Dr. Vanessa,
Yeah.
we can't view the video.
Ồ, đây này.
Okay. You can view the video.
No, we cannot view the video.
Đây là
Okay,
một
okay.
nấm rất đặc biệt này. Nó mọc lên từ cây ve sầu.
Okay,
Và
wait me a little bit. So I
khi
will.
mà con ve sầu mà nó chết á,
nó không chui lên được là nó sẽ nằm đất là nó sẽ mọc thành cái nấm rồi.
không phải là cứ đất nào mà con ve sầu nào chết cũng lên được đâu bạn. Luôn con ve sầu luôn chưa lục xác lên nè. Đây nè, nấm này tôi đang phân
Wait
loại
me,
ra
maybe
và
sorry.
phủ sẵn cát. Mấy anh em ở kia đang thu hoạch.
Okay. Okay, can you hear me again?
Yes.
Okay, so that is the different between the cicada flower and the cicada neem. So you see in the picture, looks similar, right? Yeah, here and here look similar, but they are different from here on the eyes. So really white color. So here look like you think to say that the body look clearer, but here's different. But when I break the body of the cicada neem, so you see this is something like the plant, or this is the vermis. This is the vermicide, right? So not real. So the cicada, yeah. So this is different. So and also this is we can relate to the winter worm simmer grass. So it's also like a cordyceps fungus, but it's a parasite from the caterpillar body. So you see it's used in the traditional Chinese medicine, and also, and you know, again this one, the cicada flower. So the cicada flower, they also used in the herbal Chinese medicine too. Yeah, so let's see, when I have a talk this topic in the conference of traditional Chinese medicine in Japan, so they also some of physician, I mean that from the traditional practitioner, they asked me because they use cicada flower in the traditional medicine, so in their country, like in Hong Kong or China. So they think it is not that, they told me that this is not toxic, it's not poisoning. But why I say that is the poison, that is a toxic. So I just said that is the real case when our in the patient admit to our hospital. So you see, as for cicada flower in Chinese name, so they say Changhua. So this is, and the name of the fungus is Cordyceps sobolifera. So, and also you can see that on the slide, so many chemical compounds found in the medicinal Cordyceps cicada or Cordyceps sobolifera, so many things, right? So they think that all of these are good for your health. Yeah, but for something else, to make them toxic, to make them poisoning, they didn't show. They didn't show or didn't tell you about it for in our case. And when, because based on the same symptom of the patient, it's the neurotoxicity. When we check all of the mushroom poisoning, many mushroom poisoning. So I can identify some of toxin. So I think about that is a muscarinic, muscarine, hypotonic acid. So, and then I asked the lab, can analyze for me if we can see something in this fungus in our country. So, and after they analyze it, so they found that there are the hypotonic acids in this fungus. And our fungus is named Cordyceps heteropoda fungus. This is also the Cordyceps family. So that is the poisonous. And I think this case also met in Thailand, right? I remember some of Thailand physicians, they also told me you have several cases, yeah, for the same our country. Yeah, and also I remember one or two cases in Hong Kong. They also report, but I think not look like not academic the journal, so it looks like just a daily news or something like that. So they have a case for that's it after the patient eat the cicadanine, so they have a poisoning. So and another case also interesting. So as you know, the red snapper fish see also a famous and popular, and in Vietnam many people like to eat this fish. So they said that, oh, this when I say that red snapper can make you poison, it's toxic, they have a toxic on cadmium, they surprised because they told me that so red snapper for eaten is very delicious, so why they can make you poison, right? So and they say that they fishes, yeah, the fishes and they eat it, it's no problem, nothing happened. But so what happened to my patient when they ate this fish? So you see in the picture, so that's it, the fish the patient showed me. Yeah, it's a big fish, about 4 to 5 kilograms. And they were fishes in the Chonsa Island. Yeah, in very far in the sea, is very far. Yeah, and it is island from of Vietnam. So and they said their friends, they say that because they like her very much and her family very much, so they give this fish to them, and not only one fish, they give 2 or 3 fish, the big one, yeah, the big fish to them to cook something to eat. And at that time, so in Vietnam, so we cook a hot pot with with this fish. So you see it look delicious, right? The hot pot here. If you come to Vietnam, you can try the hot pot here. So what happened to my patient? So you see, while 5 people ate a red snapper hot pot and about the fish about 4 kilo, and after 3 or 4 hours, so our patient have a headache, fatigue, paresthesia, and lame tongue, and they feel weak. And then a female patient had rash in her face, neck, and chest. But she doesn't have vomit or nausea or diarrhea. And but 2 patients, they admit to the hospital, and they admit to another hospital, but they invite me to go there to see the patient. Yeah. So 2 patients have a disorder of temperature sensation. So she described to me that she had experienced cold sensation. So she feel cold icy feeling when she clean the teeth, mouth cleaning, and even when she went to the toilet to hand washing, she feel very cold when she touched the water from the tap. So very cold, look like the cold for IC with ice. And even when she drink the water, the water without ice, but she felt very cold, like with ice. And then when she touched on the metal, she also feel that very cold. Yeah. For example, when she touched the bed in the hospital, because she make from metal, and she touched the one, she feel very cold. And I tried to ask her, and I give her a hot water, yeah, a warm water, and ask her drink. And I asked her drink it, so how she felt. And she, for the warm water, she feel normal, it's still warm, but not, she didn't feel that warm become cold or cooler water. But when I just gave her the normal water, I mean without ice, not warm, not cold, but when she drank it, so she felt cold, icy feeling. Yeah. So let's see, so I think we can see that. So she have a temperature disorder of temperature sensation. And also the lab test showed a CPK increase in our other blood state were normal range. So I asked her more detail for information about the fish, what she ate, how she does, and how many people do that. Yeah, so, and we know that in Vietnam, so also some report say about the sugar toxin in red snapper poisoning. We have some case happened in Vietnam already. Yeah, so and you see in many years, yeah, in many years, so we have some case in the different years, and also we also identify the fish, yeah, in the Ninh Thuận and Bình Thuận. That's it from the pitch. Yeah. This is from the province is in the central Vietnam. And you see, so they also check the fish, the case in Vietnam for our 20 patient data, and they tested for cytotoxin. So there are different concentrations. So you see different concentration in the flat, in the viscera on the fish. So in another case, so I would like to share you about the parrotfish. The parrotfish. So in Vietnam, we ate parrotfish every day. They are sold in the market. So people can buy every day and they fry it. We ate it. It's delicious. But what happened to our patient again? They told me that I just go to the restaurant and the sea parrotfish. Yeah. So in this family, so there are 10 people. They said that they ate the head of the parrotfish and they ate the liver of that fish. So after eating about 7 to 8 hours, so they have a muscle pain. Very pain, they feel very painful in neck, in shoulder, in chest, and they have fatigue. So they don't feel tingling, they don't feel weakness, or they don't have a dyspnea, but they feel pain in chest. So because pain very painful, so they just look like difficult breathing, but not really difficult breathing, just because very pain. So it make them feel that. So they didn't have a nausea or vomit or diarrhea. They didn't have that. So for the lab test, so you see, so they have a CK increase, it can be increased, so and hemoglobin increase, CPK increase, right? So and other thing as normal, yeah, just here. painful, very painful, and for this increase. So what happened to our patient, right? So, and we need to perform the data, so to need to know more about it, more detail. So this is the fish our patient ate, this one. So you see this one look like a red snapper, right? What I told you a while ago. So this is the parrotfish, but we are the big one, right? So you see, and also they can sell very popular in the markets, something like that. This is a parrotfish. Yeah, they sell in the market so people can buy and eat. Yeah. So, and another time our patient, they cook this one. Yeah, the big one, the big head fish, then they ate. So, so I think after the ASEAN, so I think this is a heart disease. So, and also I also consider about heart disease and polytoxin poisoning from the fish, because some of them, some kind of fish, so they have a polytoxin. And heart disease and polytoxins look like similar, right? So something similar. So, but I need to check again. So in our case, so heart disease or polytoxin. So I think it's for heart disease in our case. So we have the patient have a myalgia and rhabdomyolysis very clear so about that. So we also see on the side symptom, also on the left test, so very clear about that. And after they consume a cooked seafood. So and we know that for heart disease, so when it happen when the patient ingests a cooked fresh water or practice water fish, but some reports they also say that many times or many various times a cooked fish they also make a heart disease. So not only the fresh water or the brackish water fish, right? And also, so some of report they also tell you, so this is a kind of fish or crawfish and even salmon. Yeah, so they also have make the patient have a heart disease. So in the cowfish, bogfish, right? So also crayfish, yeah, buffalo fish, yeah, purple fish. So that is so let's see in our case is something different from the parrotfish. Yeah, so I think that is so I confirm this is a heart disease in clinical manifestation on heart disease. So the patient, our patient have a sudden onset rhabdomyolysis with a severe muscle pain. So I also have myoglobinuria and also significant increase CK in myoglobin. Yeah, so and so some of come, but they in the some of report they say that look like the patient have a mimic myocardial infarction, but in our patient we didn't see that happen. So when we compare the heart disease and polytoxin poisoning, so you see this look like something similar. They also have a rhabdomyolysis here, but they also rhabdomyolysis here. But here, I think that they will have a peripheral nervous system toxicity. So the patient must have something else, so maybe more severe, or the patient may have a limb or body numbness, but for paresthesias, but our patient didn't have that. So, and also the heart disease even can happen when the patient eats a salmon or a cotton marine stockfish. Yeah, and for polytoxin, so occur after eating cooked saltwater pieces. So we need to mention about that. And also for polytoxin, so maybe the patient can have more symptoms, severe. For example, as a muscle spasm or seizure, or also they have a circumoral paresthesias, or even if some patients also have look like an oral temperature reversal resembling CO2 fish poisoning I told you a while ago. So this is so different. So I think that in our case, I confirm that this is a heart disease, not polytoxin disease. Yeah. And another interesting case in our case is when the patient eat the star fruit. The star fruit, we also like, Vietnamese also like to eat star fruit here, and even in our lunch or dinner, even in hot pot or in the roll. So when you come to Vietnam, you will see that look like the famous food we eat, or many foreigners like it. We roll in the rice paper, we roll many things, many kind of vegetable, and you will see that we have some piece of star fruit in the roll. So when we eat, when you make it the roll, the fat rolls to eat. But on our patient, so eat the star fruit, and then he had poison. So when I say star fruit poisoning, so people they surprised because we ate star fruit every day. So why I can say that? Okay, so our patient, so he have diarrhea, vomit, convulsion, acute renal failure when he admit the hospital. So what happened to him? So you see, I just test about this is our star fruit in Vietnam. The patient gave me because they have a star fruit tree in the garden. So he can take it. He could take it every day, to eat star fruit here. But some days, just one day happened to him. This is poison. So and I checked the oxalic acid in the star fruit. He gave me. So you see the result here. Yeah, in the result I checked the potassium. Yeah, I checked the potassium and acid oxalic. Yeah, oxalic acid in the star fruit. So what happened to my patient? So as you know, star fruit we can eat, not really portion, not much, right? So patient, even my patient ate it, he eats it every day, so for fun. Yeah, just something like that. Yeah, but in that day, my patient, because he went to the party in the morning, but he didn't eat anything because he doesn't like no food or meat or something. He didn't like, so he didn't want to eat it. So and when he came back home, he felt hungry. Yeah, he asked his daughter, his son, to cook for him for lunch because he was very hungry. So and then while he waiting, when he was waiting for lunch, so he ate several star fruit. Yeah, several. This time several, not just a little. Yeah, several star fruit. Yeah, but after that, after he ate about after 30 minutes because he's still waiting for it for lunch for rice, and then the patient has a nausea and vomit and that diarrhea a lot. Yeah, and his daughter told me that he went to the toilet, look like very long time, stay there a long time because he had always vomit a lot and diarrhea a lot in 3 hours continuously, and then he had fatigue, confusion, tremor, and dyspnea a lot, so wake. Yeah, and then so the patient was admitted to the hospital. So as you know, so to me, so what happened to my patient? To me, so I think that in star fruit, we had the oxalic acid, that's irritative substances. Yeah, so let's see, look like the trigger to the patient. So as you know, in the previous lecture from the Thailand, so she said, so we also know that so in staff food they had a carampoxin. So many some of research, so they say that so who they found carampoxin, say this is a neurotoxin. So in this they will have a responsibility for some of sign symptom for in the neurotoxicity. But in our case, so I think when the patient have empty stomach and when the patient have hungry, right? So when patient they say hungry and he ate a high dose of oxalic acid, and then he has, because that's irritative substances, so make him feel irritated. Yeah, so for prolonged vomiting. And then when you have a nausea and vomiting a lot and even diarrhea, and also then so the patient will have extreme loss of chloride and loss of hydroxide. So let's see, and then the patient have a metabolic alkalosis because when the patient admit to our hospital, and I mentioned about the plus gas, it's an alkalosis. So in this condition, so we make the patient have a tremor or short of breath. So let's see the reason why. So the patient have that more severe condition. And we also know that for oxalic acid in a high dose, so the patient we have the renal failure, acute renal failure. Why? Because it make a calcium oxalate, so it make acute renal failure in this patient. And also this patient, he had the chronic renal failure already. Yeah. So this is, so today, I mean on that day, so the patient, when many things happen to him, I mean many factors happen to him, that so it would be trigger this the conditions more severe and something happens different from daily. So even he eat staff food every day for fun, right? Or nothing happen. So for in the food reaction, yeah, for adverse food interaction in the diagram, so you see here in irritant, yeah, for this one is very dangerous here, yeah. So in our patient, so I think that because he has irritation, so that's it make the patients more severe, so look like poisoning, yeah, in the staff food. But not, I think that some of other case, I just want to mention not only the staff food only, but other fruit. Like for example, people can eat the pineapple. So you know the pineapple, we have bromelain, right? So in look at the toxin in the fruit, like in the pineapple, bromelain also makes it also irritated. And also in the mango, so we here in Vietnam, we like to eat the green mango. Yeah, the green one. Yeah, maybe look like unripe, yeah, unripe or not ripe well, or unripe mango. So, and also this week, yeah, you see here. So also have oxalic acid and tartaric acid in this one. So tamarind, right? So people like to eat the one because some people like to eat sour, so they can eat that. Yeah, and also they also make the staff fruit juice to eat or to drink. Yeah, why? Because some of my patient, one of my patient, I want to share you my patient because they said that they want to diet for weight loss. So some of them and another man, so they think that it is a traditional medicine. So because someone said to him that if he want to treat his disease, I remember some type of disease, so and advise him to buy the star fruit, and then he bought 2 kilos of star fruit and make the star fruit juice. Yeah, and after he drank it, so he admitted to the hospital because acute renal failure. So and he need a hemodialysis, and then the renal functions decrease after that. So that's it. So I think it's something very natural and something you can eat every day, but in one day something happens, it's just different, or something trigger, that's your condition, so it can make you get in poison. In another case I want to share you, so that's the encephalitis case in children in Vietnam. So it happened in the north of Vietnam. So I haven't seen in the south, but in the north, because we have many garden lychee there. So look like they can contribute, they can give the lychee everywhere in Vietnam. Just they sell it because it's a big garden there. So they said that, so you see it in the report. So we have the just happen in children. So they have a nausea, vomit, coma, fever, and seizure, and they have a diagnosis of encephalitis. Yeah, and another case also. So they also in several years. So they see that, so for the children less than 15 years old, so they call it nightmare encephalitis. So it happened in the children in the Bắc Giang province in the northern Vietnam. So, and even some cases even dead, right? So, and then after they, I think they also make the individual toxic agent screening, because why it happened? Because we can eat lychee every day, right? Nothing happened. So why the patient, why many children have encephalitis? So, and then they find that it's a lychee associated acute encephalitis in children. So why would happen with that? And you know that in India, they also have the same issue, and they also have it in some patient have a brain disease that had been linked to toxin in lychee. So and also in our patient, in the children, they also had the hypoglycemia and encephalopathy and all brain dysfunction after they eat. What happened to them? Because the children, they went to the lychee garden for the harvest the lychees, right? But the children just eat, because when they take it, when they take the lychee on the tree, so they say like for fun they just eat the lychee, right? So they eat a lot of lychees. So that means they ate the large number of 100 lychees without eating dinner or lunch. So they say they have a more serious symptom. So it look like the encephalitis. So, and you know that for uncreeped lychees, they contain the hypoglycemic A. It's a very high level. So they see make the patient have a hypoglycemia and also another symptom of neurotoxicity. But how about when we eat the reef food? And the reef food still contain the hypoglycemic A, but they say that this level is much lower. So it's okay. So just if you eat just several, it's okay, but not too much. Yeah, and ungripped is very dangerous. So after I share you to the case, so what I want to say here, I think it's for in poisoning, which depend on the three conditions. At first is toxin, and the second is depend on the constitutional background of the patient. So what happened to them, how the characteristics of the patient, and for favorable factors, so many factors in the life happen on that day, or something special happened that. So it makes the poison even something very normal, or even in therapeutic dose, it's normal every day, but it can make you poison. So, and we can say that for those cases, we can say the own disease can originate from the toxin. And we say that all of those cases I show you, there is not the laboratory test could not show you everything. Yeah, you cannot say anything from the lab state. And finding out the COVID toxin in the toxic disease, I think so we need the individual toxic agent screening when by with the method and plus with the clinical manifestation, so can give you the exact diagnosis. So again, thank you.
Dr. Vanessa, come in. Hello, okay. Dr. Vanessa, thank you very much. Come in, Dr. Vanessa. Yeah. Okay, thank you for a very extensive talk on organism poisoning. Okay, we will need to move on to the next speaker, to our last speaker actually. But a reminder again regarding regarding housekeeping. If the audience, members of the audience have any questions, please type it into the Q&A box if you are on Zoom, and not into the chat box. If you're on following us on Facebook, you can type your questions into the chat section. E-certificates for attendance of this webinar will be issued after filling in the feedback form, which we will give out at the end of the webinar. With the secretary, I would like to emphasize that when filling out the form, you need to write out your email address precisely, because we have had mishaps with this during the previous part, during part 1. So please fill in your particulars and your email with precision. Specifically for Malaysians, we will be displaying the QR code for scanning MMA CPD points at the end of the webinar as well. And if you are unable to follow us on Zoom, you can follow us on the Facebook page, CPC Faculty of Medicine UKM. That is a group, so you will have to ask for permission to join the page. Okay, let's go to our last speaker for the day. Dr. Patrick, are you around? Patrick Joseph?
Yes.
Okay, magandang araw po. Kumusta?
Mabuti naman.
Okay, Dr. Patrick is an emergency physician and fellow of the Philippine College of Emergency Medicine. He's on the board of directors, is the Secretary General, and also chair of the research committee. He is also the Philippines country coordinator for RECS, Remote Envenomation Consultation Services, and also a visiting consultant to Eastern Visayas Regional Medical Center. And he is here today to give us a talk on marine animal envenoming poisoning. So without further ado, Dr. Patrick, please take the floor.
Okay, good morning, magandang araw sa inyong lahat. Mabuhay from the Philippines. I'm Dr. Patrick Joseph Tiglao from the Philippine College of Emergency Medicine, and also a consultant from other institutions like UPPGH, CLMRH, and EVRMC. I'm here to talk about marine envenoming and poisoning. So I have no conflict of interest, and here are my affiliation as mentioned. So I just have 3 simple objectives. I will discuss some interesting cases of marine envenoming and poisoning, and discuss the syndromic effects and pathophysiological mechanism of these toxins, and appropriate management and treatment of this envenoming and poisoning. So, are you having lunch or have you taken your breakfast yet? So these are 4 seafood platters that you can choose from. Choose from the upper, right upper, right lower, or left upper or left lower platters. Which would you choose? So that's a question that you need to answer me after this report. So have you ate any seafood or marine organism in the past few days? Or else there will be death on the plate. So would you choose a baked scallop or a grilled scallop? I would rather choose both. But this movie clip is from The Birds, 1963. It was like a movie that was sensationalized because of the outbreak of the mass domoic acid poisoning of seabirds in Capitola, California. Hence, the director got this influence or inspiration to make this The Birds movie, which is an amnesic shellfish poisoning. So what is amnesic shellfish poisoning? So here is just a simple diagram. How can you get the different shellfish poisoning? So it will be coming from the toxic phytoplanktons and bacteria producing the toxin, hence being eaten by the bivalves or even the fish. And unfortunately, humans get to eat the infected crustaceans or fishes as well. So the domoic acid is the toxin that is responsible for the amnesic shellfish poisoning. It acts by mimicking the neurotransmitter glutamate, which is the most common type of neurotransmitter in the brain used by the synapses in the excite neurons. It is usually used in laboratory studies of epilepsy, similar to canic acid. So in the movie, it demonstrated that after the birds ate the toxin from the marine organisms, from the fishes, it accumulated, and the birds had the bizarre, crazy birds who tried to do something to the humans. So it's similar like a attack of the aliens. Yeah. So this is a study that was done indicating what are the symptoms when you have amnesic shellfish poisoning. So mostly the symptoms is GI, and of course there is a component of a neurologic symptom, which is usually memory loss. Most of them are admitted because of monitoring, because of the neurologic symptoms, but the symptoms usually resolve within 24 to 48 hours. So basically, the management for amnesic shellfish poisoning is supportive management. So supportive management meaning you should protect the airway, which is early intubation or oxygenation will be needed, followed by breathing and circulation. So another interesting cases of poisoning from marine animals is Clupiotoxism. Clupiotoxism was described in the Philippines in the 1980s by Dr. Alcala. We had a lot of cases of which brought about by the eating of sardines. So you know the Philippines has a lot of we are an archipelago, and most of the food that we eat are coming from the seas and the oceans. And in the Visayas region, we have a particular area like in the Cebu, in the Moalboal, we have the famous sardine schools like this one. Thanks for the photo of my friend from Facebook. This is an actual photo in Moalboal where she dived in the school of sardines. So Clupiotoxism or the toxin from the clupioids or the Clupidae fishes are poisoning from the sardines and herrings or anchovies. It is widespread in the tropical and subtropical areas. Although some reports are rare, but in the Philippines, there are already reported cases. So the reason for, or the toxin responsible for the clupiotoxism is palytoxin. Palytoxin is one of the paralytic shellfish poisoning toxins that are included in the shellfish poisoning group. So it is brought about by the blockage of the palytoxin of the sodium potassium ATPase. Hence, there is a misbalance or imbalance of the of the sodium potassium entry to the cell from external to internal, causing neurologic symptoms and GI symptoms as well. So supportive management would include, of course, airway. To support the airway, we need to intubate early and to give oxygenation, followed by breathing and then circulation. Another interesting is the HAV disease, as mentioned by the previous talk. HAV disease was historically was from the Baltic area. It is named after this. This is a satellite view of the area. This is the lake or the freshwater lake where the fishes were found to have this disease, these toxins. So the rare syndrome is characterized by rhabdomyolysis, myalgia, and accompanied by myoglobinuria, usually occurring 24 to 72 hours of consuming certain types of usually freshwater, but there are cases of saltwater fish or crustaceans. So these are just examples of freshwater fish and saltwater fish and crustaceans that causes this what we call HAV disease. So in China, there are cases of, as mentioned, crayfish causing the HAV disease. So there are a lot of epidemic cases that were documented in China as well. Then this one is similar looking like a piranha, but it's the same family with piranha, but this is a red-bellied paco. So we have also cases in Brazil and Japan as well. So what does the HAV disease cause in our body? So the CK levels is increased 5 times or 5-folds, and there will be increase or release of myoglobin and creatine phosphokinase and other muscle enzymes that causes degradation of these muscle proteins. Hence, there will be blockage of the kidney tubules, causing renal failure. So toxin is unidentified as of the moment, but it was mentioned that it's similar to a marine toxin, palytoxin. The treatment is usually supportive as well, so there's no antidote for it, and you need to give analgesia, IV hydration, and avoidance of the nephrotoxic agents that can cause further damage to the kidneys. So in the Philippines, we have this, we call it cone snails. So this is taken from another friend of mine who is fond of eating different marine animals. So you could boil or grill it, and sometimes they put it with vinegar. So these are examples of the shells of the cone snails. So as you can see, this is a very interesting collection of cone shells from the Smithsonian Museum of Natural History. You could have different types of cone snail shells, but more importantly, in the Philippines, we have one of the most toxic cone snails in the world. We have the Geographus and the textile, the Conus species. So as mentioned, Alcala already documented those cases during the 1980s. So there are a lot of cases of stinging, usually by the fishermen who do their fishing in the low tide, and then they suddenly pick or step on a cone snail, hence they are being stung. Or some of them put the cone snails in their wetsuit, in their pockets, hence they are being stung by the cone snails. So in the Philippines, we have different types of cone snails located in different countries. This is one of the most popular one of the most popular locations would be in the middle part of the Philippines, which is Cebu. So most of the fishermen there harvest cone snails for a living. So clinical presentation, as mentioned, would include mild to excruciating pain. So most of them would yield neurologic symptoms like weakness, diplopia, muscle paralysis, respiratory failure, coma, cardiovascular collapse. Deaths are even reported. So most of the cone snails are very attractive looking. So, and when we go to the beaches, you can see a lot of cone shells scattered around the beaches. So be careful if you see a very attractive looking shell, don't pick it up first. Look if there's an animal inside. So prevention is better than cure. So the first thing that you will do if ever you're stung or a person is stung by a cone snail, especially that this cone snail stays in the water. So remove the patient from the water to avoid drowning. And then of course, there's no antidote or antitoxin for this. So supportive care is needed. You can do pressure bandage immobilization, pain control, and of course, transport to the nearest hospital. So let's see this video.
Masarap ang alimango, pero meron palang klase nito na nakalalason. Siyang nakain ng isang pamilya sa Cagayan. Kaya pare-pareho sila.
Okay, we just saw the video of a, sorry for there's no translation, but the story goes, the father hunted or got crabs along the shore and the shoreline, and then cook it and fed it to the children. Unfortunately, two of his children died. He was intubated as well, but the father survived. So what caused the demise of the children, and what caused the father to be intubated? So as mentioned in the video, it was a certain crab they call it kurit in the Philippines, and it's commonly familiarly called devil reef crab. That's why you should not eat it, because it's a devil reef crab. So most of the components of this devil reef crab would be tetrodotoxin and saxitoxin as well. So most of the crabs that causes this would include the santid crabs, containing the paralytic shellfish toxins, tetrodotoxin, and palytoxin. This is an example of a poster from our Bureau of Fisheries and Aquatic Resources indicating which of the crabs that you should not eat because it contains certain toxins. So there are a lot of studies being done in the Philippines with regards to these toxic crabs. So including one of them is this one crab located in the middle of the Philippines in the Cebu Islands, particularly in Camotes Sea. So there are a lot of cases of crab poisoning there as well. So this is just a diagram showing how does the tetrodotoxin was produced, specifically from the marine bacteria that is eaten by the planktons and the feeders like the fishes. And then unfortunately, people get to eat these infected or these fishes or crustaceans that has this tetrodotoxin. So Alcala also had these cases in the 1980s, 1960s actually, 1960s to 1970s regarding this cone shell crab poisoning and fish intoxication that are well documented. These are just case reports, but they are indicative that and evidence that really there are a lot of marine envenoming and poisoning here in the Philippines. So this is an example of the culprit as mentioned by Alcala, which is this type of crab, Lopozosimus pictor. Yeah. So what does tetrodotoxin effects in the body of a human person? So first, it can cause you drooling, sweating, fixed dilated pupils. It can cause you neurologic symptoms. We have certain grading for this tetrodotoxin poisoning. So More familiarly, TTX poisoning are from puffer fishes, but we have crabs, we have crustaceans as well. So the effect or the pathophysiologic effect of tetrodotoxin is that it causes the blockade of voltage gated sodium channel, inhibiting propagation of the nerve and muscle actions, causing neurotoxicity. So it does paralyze the person. Hence, the first priority would always be the airway. However, since most of the time, the patients are being brought late in the hospital. So better if they're being brought earlier and so that they can be intubated early. So supportive treatment, as mentioned, would be the airway, followed by breathing and then circulation. So this is a picture from Thailand. Just recently, I think it's around January or February, that was circulated in the newspapers. This is a street food famous place in Thailand. So as you can see, there's a odd-looking octopus, small octopus, right on this part. So you can see small dots, and if you look thoroughly, there's like a ring, blue rings on it. So it is a blue ringed octopus. So the newspaper called the attention of the authorities regarding this, because blue ring octopus contains tetrodotoxin. So tetrodotoxin is heat stable, meaning it can survive in high degrees of heat. Even if you cook it, there will be evidence that it can survive in high temperatures. So this is an example of a recent use actually last March, when a certain beach goer went to the beach in somewhere in Australia, and then she held the cute looking octopus, not knowing that this is one of the most venomous marine animal. So you can see the fascination because of the people with these creatures, because of the texture and the color that these small octopuses have. So this is also an example of a beachgoer who tried to make fun of the octopus, not knowing that this is one of the most venomous marine animal. And unfortunately, some of them survive. As you can see in this picture, this is a fisherman who accidentally stepped on a blue ring octopus. So you can see that there is a pressure bandage immobilization that's going on, and patients survive. So usually, if you're bitten by a blue ring octopus, it would be painless and there will be no signs. Only small, some would have small spot of blood, but it can cause systemic envenoming in minutes, progressive symmetrical descending flaccid paralysis that can cause early on perioral paresthesia and numbness, ptosis, blurred vision, diplopia, and difficulty swallowing, and also generalized flaccid paralysis, aphonia, fixed dilated pupils, and respiratory failure that can cause, of course, death in minutes. So there's no antidote available, and supportive care, as mentioned, using the pressure bandage immobilization, and of course the ABCs. So actually, one of the treatment or prevention would be do not touch anything in the ocean if you don't know it. So the summary that I have here are, as mentioned, on those cases or those marine animals, that the global impact of marine envenoming on human health and activities is largely unknown. Some of the toxins are still being studied, and actually, conotoxins are being now used as analgesic. We call it Prialt in the US, more potent than morphine. So these toxins can be beneficial and harmful as well. So the mainstay treatment is usually supportive management because we don't have antivenom, and airway, breathing, and circulation. Early intubation would be the most important thing that you should do to your patient with urologic symptoms that is progressing, and you should avoid seafoods with toxin. So, and of course, the public education, whether or not these animals or these marine animals have toxins in it. So, going back to my question, which platter would you prefer? Anyone? So here are my references, and salamat po.
Oh man, Dr. Patrick, you stole my line. I was going to say salamat po actually.
Yes.
Okay, all right. Thank you very much. Thank you. All right, so okay, that is the end of the 4 speakers. So right now we're gonna go back to the housekeeping rules. You have any questions? The audience, if you have any questions, if you're on Zoom, type it into the Q&A box. If you are following us on Facebook, type it into the chat box. You can follow us on Facebook on the page CPC Faculty of Medicine UKM. It is actually a group, so you will have to ask for permission to join. You can type your questions there in the chat section. At the end of the webinar, we will be giving a link. We'll be issuing a link which you can click on to get the e-certificates. Make sure that you fill in your particulars and your, especially your email address properly, so that we do not get any mishaps or any errant emails. For Malaysian specifically, we'll be displaying the QR code for the to get your MMA CPD points for this talk, also at the end of the webinar. Okay, so after this is the Q&A session, or basically it will be
our Q&A session. I would like to invite all the panelists to open to start the video. As we will start with Q&A session.
Okay, can you start the Q&A session now? Okay, all right, can everybody hear me?
Yep.
Okay, all right. Okay, so welcome back to the webinar. We are now at the Q&A session / forum slot of the webinar. A lot of interesting questions have been posed to the speakers in the Q&A box. So I will be reading them out and fielding them to the speakers as appropriate. Okay, first question is for Dr. Anas Amri from Malaysia. Okay, the question goes, in patients with respiratory paralysis requiring intubation, what RSI medications are the best option for the patient? And do we need to use muscle relaxants?
All right. I think for the RSI in respiratory paralyzed patient, I think what the question meant was mainly for the use of muscle relaxant. Okay? So in elapid envenoming, usually the pathological changes is actually more or less resembling some sort of myasthenia gravis punya pathological lah. So I think there is no issue on that. If patient is totally paralyzed, I think you can just intubate with sedations. But however, if you need to use muscle relaxant, you can opt for the smaller dose of the depolarizing agent, smaller dose, or in case if you need a higher dose, if you need to use a depolarizing agent, then you need a higher dose of the scoline. or depolarizing agent. So, but more or less, if patient totally paralyzed, I think you might skip the paralytic method. Maybe other expert want to add on, Prof.
Yeah, there's no issue on giving the usual RSI drugs in patient with snake bite, but you have to understand that the patients may have some time before you need to do another reassessment of the progress. So that one can be assessed, let's say after 6 hours after the initial intubation period. So there's no issue on the RSI drugs that can be given to the patient.
And other than that, beside your sedation, your induction, I think you may need to look at the clinical hemodynamic status of the patient, whether the patient is hypotension, patient the pre-existing comorbid, IHD, etc. I think not so much difference between other non-snake bite patients.
Okay, all right. Thank you to Dr. Anas and Prof. Khaldun. Prof, okay, next question is for Dr. Vanessa. I think I will just ask you two questions in one go, because the first question is more of a clarification question. Someone has asked here, what meant by ITAS and LEWT? What are those terms referring to actually?
Yeah, that is the way my working when I want to find out the conflict toxin for the poisoning patient. This is ITAS, individual toxic agent screening. So because it's important because as you know, in the poisoning sometimes we cannot base on the test, because some physicians think that the lab test is important to make a diagnosis in the poisoning. So I think it's not true and not real, and not true in the case of poisoning. So that is important to find out the toxin.
Okay. Yeah. Okay. So basically, it's a toxin screening. Yeah. Okay. All right. Okay. So on to the other question. Okay. Regarding the cordyceps fungus in cicada nymphs that contains ibotenic acid, is it limited just to cicada, or can it occur in other insects like ants, crickets, or spiders? Which and can it lead to similar presentations? As in some countries, crickets are part of the population's diet.
Actually, I cannot say about how the cordyceps parasite on other insects, because in my country it happened in cicada nymph, and based on the sign symptom of the patient, so I make the diagnosis, because those sign symptom is like the neurotoxicity. Yeah. So and we check when we check on the check in the sign symptom of all the mushroom poisoning. Yeah, I think you can read this mushroom poisoning in the textbook on type of mushroom poisoning. So and then I can group our sign symptom of our patient. So I group on what kind of toxin we can think about or relate to that sign symptom. So I think I found that case relate to muscarine, ibotenic acid. So let's see, I asked the lab on the lab to find to look for it done for me, and even for the cordyceps when they parasite on the test or the worm. So I think we can if you have the patient show you to eat those ones, so you can check if they have any sign symptom or not related to that. So we can group in the group of the sign symptom what kind of them, so we can check. Yeah. So if you ask me for another cordyceps, So I cannot say that.
Maybe
But I remember in the cordyceps, I mean the winter worm summer grass. That is Chinese traditional Chinese medicine. It's very expensive, and many people they use now very popular now. But I read in the textbook of traditional medicine. When they test on the rabbit on rat, so they have in the high dose of the cordyceps fungus, even the rabbit or the rat they still die. Yeah, for that one. So and also when I read the same symptom on the rabbit in the rest when they do an experiment on those for the winter's warm summer grass, is still the same our patient. I mean the same symptoms still the same our patient. So I think this could be the same.
Maybe Prof. Sataria in Thailand, I think we had a few cases on some insect infected with the fungus as well. I'm not sure if Philippines also.
Yes, we have about 30 cases from cicada nymphs poisoning consulted and referred to our poison center also, but we do not have the lab to test ibotenic acids. Yeah, so we diagnose mostly from the clinical diagnosis history and examinations like that.
Yeah, we are in Malaysia. Not so many people eat these insects, so we don't go around looking for them in the ground or in the trees. So I'm not sure in Sarawak though, or Sabah, they may be closer to nature and have more options of this kind of food. Yeah, Philippines, I don't think so.
I think we have isolated cases. That was a case report of a cicada, because most of the time, from the mountains, what they see that is crawling there, they fry and eat.
But this is a special cicada. I mean, it's a cicada which is in the ground, and it is not the cicada itself. It's from the fungus that grows on them. So
in our country, because it looked like the patient is accidentally, because they thought that it's cicada dim. They didn't think that it is a fungus. So they just think so it's easy to catch, just get out in the ground, easy. They don't need to catch in the tree at night. It's very hard work, right? But easy just on the ground in the morning. So that's it, just accidentally. So
okay, good question. Thank you.
Okay, thank you. Next one is for Prof. Sataria. Okay, regarding DNA analysis for unidentifiable plants, how do we keep the sample to send them for analysis? Should they be dry frozen? Should we dry freeze the plant or use any other some sort of preservative?
No. Okay, thank you for the questions. And in our poison center, we have the expert botanist. He is a consultant of our poison center about the plants poisoning and herbal poisoning. So he recommended us to tell the patients or the doctor who would like to send for the plant identifications or DNA analysis, that for like DNA analysis, you have to wrap the leaf of the plants by the tissue paper and put it in the Ziploc bag, and then add the silica gel as the desiccant or drying agents, and then you can send to the botanist or the faculty of science to analyze for DNA analysis. And for plant identifications, the botanist recommend us to dry the sample first, and you have to collect all parts of the plants as much as you can, like the flower, the leaf, the stem, and take the picture of the plants and also send to the botanist to help identify of the species of that plant. And after dry the sample, you have to wrapped with the newspaper paper and then sent to the botanist as soon as you can. Yes, that from the recommendations of our expert from our poison center. He does not recommend to freeze it in the refrigerator. So dry it first for plant identifications. Yeah.
Okay. Okay.
It's-
All right.
it's
Thank you,
this-
Prof.
Yeah, it's the same kind of advice that we get from our botanists in the Forest Research Institute in Malaysia as well. I don't think we have yet a botanist in our own poison center in Malaysia. The question is now, I think, since we have already a network, wonder if we can actually utilize your expertise in the Ramati Bodhi Poison Center, linked via networking like this, via video, to identify plants as well. So the ones that we have collected, maybe we can show it to your experts and make it identified. It can be identified for us as well. So it's something that we can try and plan in the near future, how we can utilize these experts.
Yeah, we can collaborate.
Yeah.
Especially for the pictures or the photos that I think that our expert can help identify. Yes.
Okay. Thank you. Okay. Next question is for Dr. Patrick. Okay. Let me see. Lost the question. Okay. Dr. Patrick, in your country, has your organization, whichever organization you are involved in, have they started a depository or repository of documented cases of marine envenomation?
Yes, thank you for that question. So first of all, we have government hospitals or poison control centers who document as well. But we also have non-government, which is REX and of course Pythons, who we started collecting those marine envenoming and poisoning cases, as well as snake bite cases as well. So these are the most common agencies who collects those data. But there's no registry yet for the government.
Okay. All right. Thank you. Okay. Next question back to Dr. Anas, and I think Prof. Calvin can answer this question as well. Okay. I think the asker sounds like she's someone from maybe a district hospital with less access to medical facilities. The question is, since our antivenom is very limited. Oh, okay. I'm not sure if this patient, sorry, if this asker is from Malaysia or someone else, but regardless, the question is, since our antivenom is very limited here in our area, we reserve them for neurotoxic manifestations. For tissue necrosis, we refer them to surgery for debridement to halt progression of the necrosis. We also start antibiotics like intravenous clindamycin. Please comment on this.
Okay, I think, as we all know, usually the envenoming, we start from local to systemic rather than systemic to local. So in the case where you have limited antivenom, I know some practices will really put a high threshold on giving starting antivenom just based on the local envenomation. So, but yeah, if patient presented with the significant tissue necrosis like dermonecrosis, massive swelling, and etc., I think antibiotic is warranted, and plus minus surgical debridement if already well demarcated. But in the sense of antivenom, I think it depends on the locality of the antivenom, I think.
Okay, all right, Dr. Holden, any additional comments?
I think Prof. Sataria can also share experience on antivenom for snakebite in Thailand, because we import the antivenom from Thailand. So what's your threshold of giving antivenom for local or for systemic only?
So now from our Thai Red Cross recommendations, we will not give antivenom to the patients with only local effects from snake bite. We will give only for systemic envenomations for both hematotoxics and neurotoxics. However, if the patients develop like compartment syndrome from hematotoxic snake bite or envenomations, we can use the antivenom in that patients. It's exceptional, but only like local symptoms, we will not give antivenom to our patients. It's from Thai Red Cross recommendations, and it's our practice now in Thailand. Thank you.
Yeah, thank you.
Okay. By the way, the one who asked her name was Ella Perez. So I'm gonna make an assumption that she might have been from the Philippines. So if Dr. Patrick, if you have if you have anything to add, you're more than welcome. Or can we go on to the next question?
You can go to the next question. I think
okay.
they both answered the question.
Okay, all right. That was just a stereotypical assumption on my part, looking at the name of the asker. Okay. Next question. Okay, Dr. Okay, I think we'll go back to Prof. Sataria. There's another question for her here. Okay, Prof. Sataria, regarding the Dieffenbachia, is that the Damkane?
Yeah.
That's a Damkane, right? Yeah. The Damkane plant, I have heard that it can prevent dengue larvae, I can prevent deposition of dengue larvae. So is it planted commonly around the house for this reason? And since you did, it's a two-part question, since you did mention that it's via skin / cutaneous / mucosa, so does that mean by simply touching it or rubbing against it, the leaf can cause injury, or do you have to be in contact with the sap, or do you have to ingest it? There's a bit of a running sentence here. Does the calcium oxalate do the calcium oxalate crystals lie on the surface of the leaf per se?
Yes, so for the Dieffenbachia or Damkanes contain calcium oxalate crystal in many parts of this plant. So if the patient touch or ingest it, it can cause like microtrauma from the larvae or calcium oxalate crystal. And I think it can release the proteolytic enzyme that can cause just more painful. So you have to be careful when you would like to touch or touch this plant by the bare hands or something like that. So you have to be careful. I think many parts of this plant contain oxalate, calcium oxalate crystals, and it causes microtrauma to the skin or GI tract. And it is insoluble, so that's why when you eat this plant or the sap of this plant, it can cause the trauma by calcium oxalate in the upper GI tract, like that.
It's a irritant to the mucosa.
Yeah, mucosal injury.
So the another issue is that it's not just us that is going to be at risk, but also mainly the worry is our pets in the house as well. So a lot of people keep this plant as house plants. So, and they forget that the animals in their house, like cats, like to chew on the leaf of this plant, and they can actually die from this calcium oxalate poisoning. So that's why be careful when we are buying plants, choosing which plants for the house. And if we have pets in the house, they can also be at risk from poisoning of these plants.
Yes, I totally agree.
All right. Okay, thank you. Next question is from Facebook. Oh, Prof. Khaldun, are you speaking? Because you're mute. You're mute. No, okay. The next question is for Dr. Patrick, and it's from Facebook. The question is, here in Malaysia, especially in Sabah, we have a seasonal phenomenon called the red tide. And I think this refers to algae, if I'm not mistaken. So do you have any experience handling it in the Philippines? And if so, would you mind sharing your experience with us?
Yes, the Philippines is, is surrounded by water as well. So we have a lot of seasons of red tide. So most commonly, it will be on the rainy season. And then the government will announce whether this red tide is ongoing in a certain area or region to tell the people or to announce to them that they should not eat this certain fish or marine animals within that region or area. So usually it's included in the weather forecast. So or the news as well. They will announce it that there's a red tide in this part of the country. And even the sellers or the ones in the supermarket would know whether or not to harvest or sell these marine animals.
Okay. All right. Okay. Thank you, Dr. Patrick.
Yes, I just want to add a bit about this red tide thing. There's some people think that we can only get poisoning from eating the marine animals that is already tainted with the duetone from the red tide. But let's say, for example, there are cases in France where they have very strong wind and the wave carrying the red tide crushing on the beach. It actually becomes a water vapor. And this duetone goes in the air and people are actually breathing it in. So you get poisoning from that as well. So not just you eat the fish or the animal from the red tide tainted area, but in cases of a big storm and so on that can crush the red tide, it can actually disperse the duetone in the air. You can get poisoning from it. So there are cases in France near the coastal area that happen can get this type of poisoning from the air. It's very interesting.
Interesting indeed. Okay, thank you, Dr. Patrick and Prof. Khaldun. Next question is let's go back to Dr. Anas. Okay, Dr. Anas, would it be appropriate to use neuropolyvalent and hematopolyvalent antivenom for stick bite cases instead of the specific species antivenom?
If you know or if you can confirm and identify the species that bite the patient, I think the first choice is of course monovalent or specific antivenom rather than polyvalent. Okay, so to answer that, yeah, I think we go for monovalent if you're able to identify. However, in such cases where you can't identify, for example, patient came in with neuro symptoms, so you might want to use a neuropolyvalent rather than specific monovalent antivenom. Okay. But if you've got a choice, you know what is the species, you can confirm that, or you've got a clue, for example, Naja species bite presented with the monocrosis, so you go for a specific monovalent antivenom.
Just to add a bit, even though it is a polyvalent, the name is polyvalent, it's actually a polyspecific antivenom. So it's not to give that polyvalent so-called if you just don't know the species. No, that's not the reason why you give a polyvalent antivenom. It's based on the sign and symptoms that patient presents, and that will narrow down to the possible species of snake that bite the patient. So that's how we choose which antivenom to use. And even if it's a neuropolyvalent, there are, for example, from Thailand, Thai Red Cross, the neuropolyvalent is 4 species of snakes, and the polyvalent is 3 species of snakes. So the choice of how you keep or buy or purchase the antivenom also will depend on the area that you are in. For example, Dr. Anas is in Sarawak. There is no Malayan pit viper or the Siamese a viper in Sarawak. So there's no need for them in Sarawak to keep hematopolyvalent. So their choice of antivenom is only for mainly the Trimeresurus complex species. So they are just keeping the green pit viper antivenom in Sarawak, or in Borneo actually. So that is a very interesting data that you should try and gather from your own hospital. What kind of species of snake that you have in your area, and the list of patients that get envenoming requiring antivenom.
Okay. All right. Thank you, Prof. By the way, for those of you who are wondering, Malaysia is a country separated by the South China Sea. We are here in the peninsula just below Thailand, and Dr. Anas is in Sarawak, separated by the sea. So the flora and fauna may differ significantly in some cases. Okay. Okay. Next question is for Dr. Vanessa. I think she might have answered some. Okay. Oh yeah. She answered she typed out the answer to the question in the Q&A box, but I'll just pose a question again so that everyone can listen to the answer. Dr. Vanessa, is the cicada flower at a different stage of growth before they emerge from the ground, or is it contaminated when they are already living in the ground?
So as I answered it, that is a different taste. It's become the plant because from the insect become become the plant because it is infected. The spore of the fungus inside during when the cicada nymph live in the ground, and then the spore, the fungus infects in the body and then develop inside the body. Yeah, so let's see when and then after, because you know, as you know, the cicada nymph live in the ground very long time, several years. I remember the horn periods to develop from the insect to the adult cicada, right? So the major cicada is 8 years. I remember 8 to 12 years. So that means they live in the ground very long time. So this is the time for when the fungus infected inside, so they develop it. Yeah, so this is a contaminate. We can say that. This look like the disease of the cicada nymph. Yeah.
Okay. Okay, thank you. I think Dr. Patrick, I'm going to do the same thing to you. You just answered a question in the Q&A box, but for the benefit of everyone listening, I will pose the question again to you. In Malaysia, we have many canned sardines in the market. So is there any possibility of us getting palitoxin? Oh, we can't hear you. Okay.
Yes,
okay, yeah. Okay, now we can hear you. Yeah.
In the Philippines, we also have manufacturers of sardines, canned sardines down south in the Mindanao area. So mostly those producers of sardines have their own monitoring and safety guidelines that they should know, and they are being monitored by the Bureau of Fisheries as well. They know when to harvest and when not to harvest those fish, especially the sardines, during the time that there's algal bloom or any toxins within the region. So I haven't heard any case of sardines induced toxin due to the palitoxin. Yeah.
Okay. Prof. Sataria, this question I think is intended for you, this next one. Would you recommend demulcents, for example, honey, if calcium oxalate is ingested accidentally?
Okay, so supportive care, and like some will recommend to use the ice or use the water and then not swallow but decontaminate with the water, and some will recommend the ice or other soothing agents or like analgesics. And so the pains will last for like many days in my experience, like, and some patients have the pain for like 4 to 4 days to a week. So you have to like maybe give the analgesics to the patient. So symptomatics and supportive care are the main treatment for calcium oxalate crystal by injections, toxicity by injections. And but if you are in ER, you have to be careful in the severe cases. They might develop like airway compromise or upper airway obstructions, and you have to be careful about the airway of your patient.
Professor Tare, you get mainly children or adults in this kind of poisoning accidents?
I have never collect the data of this type of poisoning, but I think both like adults in our country still exposed to dumb cane toxicity. Yeah, I think that we have the cases, not many, but it's not rare. But sometimes like the sap squirt into the skin to the GI, and one of the death cases in our study, that pan poisoning, that one he ingested because of thing is like an earth, and ingested quite a large amount of the sap of diethylbashir and developed like hemorrhagic gastroenteritis and shock. Yeah, and it can cause death in the severe case.
Yeah, I would have thought that children probably have more severe response to this, and plus as the pets, children are also probably susceptible for houseplants poisoning.
Yeah. So we will look at our data again, that maybe we have to prevent this type of poisoning. Health educations may help for this. Yeah.
Yes.
Thank you.
Okay, thank you. Okay. All right. Okay, I think Prof. Khaldun, I think you can answer this one. The question is, in Malaysia, if suspected marine organism, or if there is a case of suspected marine marine organism envenomation or plant poisoning, how should we diagnose it? Is there any laboratory that that can help us in further investigation or analysis of the organism or plant?
Okay, so the answer is already being actually mentioned by all the speakers. Most of them are starting with acute presentation. There's nothing that we can do to test immediately. There's no bedside test that we do to check which toxins they are. So it's not like if you have like some other toxicant poisoning, chemical poisoning, you can do some tests, analysis in the lab, but not for toxins per se. So we rely mainly on the clinical presentation, how good your your history taking about the case. And I think last week we had a very good talk by Prof. Usui from Japan regarding analytical toxicology, where we have to think like a police investigator, forensic medicine, thinking of how to establish the case and what are the evidence that is available. So let's say, for example, they eat something and they can describe what they ate. That could be actually helpful for us to determine what type of symptoms that appear to which type of food that they eat. For example, Dr. Patrick just now showed us a plate of all kinds of seafood, and then patient came with a certain symptoms from symptomatic analysis that we do. Clinically, we can try to point which type of animal in the plate that the patient may get poisoning from. And from our experience as well, as what happened in Sarawak last time, patient ate normal fish. I mean, they eat not poisonous fish, but they get symptoms of a poisonous fish and tetrodotoxin poisoning. So when we look back at the sample of what, and we ask the patient what else was cooked in the steaming pot, there is actually a row from puffer fish being steamed together with the other fish. So the other non-poisonous fish get tainted from the poison, the tetrodotoxin poison from the puffer fish. They say they didn't eat the puffer fish egg, but they ate the other fish which is cooked together in the same pot with that puffer fish. So they also get poisoning from that. So it's very important to get all this evidence in your history taking clinical and look at the symptomatic development. I would like to congratulate Prof. Sataria mentioning about all these herbal and plants. I think in all poisoning, the amount that is just ingested can actually present a different, how should I say, range of severity of toxicity of clinical symptoms. So this is also another, I think, skill that is a clinical skill that is maybe earned through experience and by asking all the other experts on one kind of poison. It's not necessarily just one type of symptoms. It can be a range of development based on the amount of toxins that have been exposed. So I hope
Okay,
that answered the question.
Thank you for
Anything else
this.
you'd like to add?
Yeah. Okay. All right. Okay. Thank you for the extensive answer. Okay. Prof. Sataria, there's another question for you. Okay, if a patient comes with a cactus needle prick, and after we remove the visible needle, do we still need to do an X-ray to exclude if there are remaining needles, or can we just let the patient go?
I think that the cactus has the spine, and most cactus have the last spines that you can see by the eyes. And I don't think that the spine is radio opaque, but you can be visualized by use the ultrasound equipment. So you can use ultrasound if you suspect that the patient has remain the remain spine in the wound. But for the last spine, that we recommend to remove by the tweezer or forceps. That is enough for almost all patients. But some cactus has the fine spine, or we call like growth sheets, that we will recommend the different method, that we use adhesive plaster or the household glue to remove that fine spine. And for deeply embedded spine, sometimes we have to remove under the local anesthesia to prevent the secondary contamination. So, but it's quite rare because most have the last spine and remove very easily by like the forceps or tweezer, like that. Yeah, I don't think that we need the X-ray, but ultrasound can help identify remain spine in the wound, I think.
Okay, thank you very much. Okay, last couple of questions before we go to the next, the last slot of the day. I think I'm going to direct this question at Dr. Patrick. May I? Okay, the question is, if someone gets bitten by a snake and was unable to identify it, and presents to the hospital complaining of a supposed snake bite, but there are no or there are very minimal details. Should treatment or anti-venom, or more specifically anti-venom, be given?
First of all, in the Philippines, we have limited antivenom. So most of the time, we do supportive management for the patient. And then if you're lucky to have the specimen of the snake, there will be someone to identify. Like in our case, usually our herpetologist in Rex identifies the snake even in other hospitals, and then that's the time if the patient has symptoms, neurologic symptoms, that's the time that they can give the antivenom. But most of the time, they just do supportive management since there's no available antivenom.
Okay, thank you very much. Okay.
I think on that line as well. Sorry,
Yeah.
there's one question about coral snake envenoming as well.
Oh,
So
yeah.
it
There was a
it
question.
applies the same. We don't have specific antivenom for coral snake. So far, the experience that we had in Malaysia of coral snake envenoming mainly symptomatic as well. So it kind of playing with time. It doesn't go to other complications, like say, for example, renal failure or hepatotoxicity or cardiotoxicity. So it's mainly local, and occasionally we get some seizure symptoms, but otherwise we don't have any specific antivenom for coral snakes in Malaysia, in our country, or even in the region. Which is different from the coral snake that is mentioned in the US. So don't get confused between the two.
Okay. All right. Okay. Last question of the day for Dr. Anas. We have 3 minutes left. There's a 2-part question. I think you can answer it within that time. Are there any cases of paraspecificity of nausea antivenom for king cobra bite? And that's part 1. Part 2 is what antibiotics would you recommend for snake bites?
All right, I will answer the second question first. The first question, I think I will leave it to Prof. Okay, the questions regarding antibiotics. First, the participant asked, do we usually give antibiotics for snake bite? The answer is not all, but depends on the presentations. Antibiotics in snake bite usually indicated whenever there is presence of, for example, tissue necrosis or tissue injuries. Okay. Or I usually consider in patient with immunocompromised state. So I would start some antibiotic. Antibiotic of choice will be either broad spectrum augmentin or unisim. Okay, we don't usually start prophylactic antibiotic for all snake bite patients. Depend on the wound, depend on the state of patients. All right. For question number 2, I don't really get what did Arapeles mean? Are there case studies of paraspecified? Does she mean that
I think
Naja, the NKAD to use for king cobra?
Yes.
Okay.
Yeah.
To be honest, maybe I let Prof or other experts.
Okay, so there are always a preclinical testing of antivenom before use in the clinical setting, and we see how many other species that can be cross-neutralized with the antivenom, and this is being done in Thai Red Cross as well. So yes, there were tests, experiment done to see whether the Naja cautia antivenom can neutralize the Ophiophagous hana venom. It shows that there is some of the toxins can be neutralized, but not all of the toxins. Most of the time, it doesn't really work. So you have to understand that venom is not just one toxin. It's a multitude of a range of toxins and proteins and enzymes and so on. So from one species to the next, it may not be having a good paraspecificity. So far, the study that we have conducted, even in Malaysia, the Naja cautia antivenom does not cross-neutralize to Ophiophagous hana well. It doesn't neutralize the Ophiophagous hana well. So that's why we have Ophiophagous hana antivenom on its own. So maybe Prof. Sataria would like to comment on this as well.
I have no any data about cross neutralizations, but now we recommend the antivenom for specific snake type. So like for cobra bite, we will use monovalent for cobra antivenoms. We will not give the different type. And sometimes in my experience, I think it does not cross neutralize quite well. Like for some patients with hematotoxic snake bite or envenomations, we gave them like the different type of antivenom because of right, the patients told the history of the different snake like that. And after giving the anti-venom like Malayan pit viper to the green pit viper patients, it doesn't work well in my experience. So I think that if you know exactly that which type of the snake, I will recommend that type of antivenom for that snake. Yeah, but I am not sure about the data that it can cross a little bit or much. I have no idea about that, and wait for the result. That if it can be used for different species, it might help. But I know that some antivenom they use for different species like hamnose in Malaysia, that they use Malayan pit viper. I'm not sure, and ask Dr. Carl about that.
We don't have hump nose in Malaysia, but we
Oh,
have
really?
we have mangrove pit viper. So we do find that there are actually studies done that Malayan pit viper antivenom doesn't really neutralize the green pit viper's venom. That includes the mangrove pit viper. So that's why the mangrove pit viper venom appears to be better neutralized using the green pit viper antivenom. Because it doesn't affect the the platelet issue. So similarly, the green pit viper doesn't neutralize the Malayan pit viper venom. Interestingly, to add also is that even though it's from the same species of snake, the antivenom may not be effective for all of them, even in the whole region. So the study that we did recently from Universiti Malaya, Dr. Tan Chu Hock and his team look at the geographical variations of king cobra venom against the Thai Ophiophagous hana antivenom. So at the moment in the world, the only country that produces king cobra antivenom is Thailand. So we have only one. It works well with the Thai king cobra, but it works not so effectively. I mean, not as effective compared to the to Malaysia, the king cobra in Malaysia, king cobra in Indonesia, and also in China. So potentially we may need to use more antivenom from king cobra if it happens in Malaysia compared to Thailand. For example, in Thailand you may need to use only 5 to 10 vials, but in Malaysia maybe we need to use 15 to 20 vials for the same amount of for the same envenoming. Okay, so that's the reason why we are embarking on this project called the antivenom burden for ASEAN. We hope that we can actually improve.
Prof, are you still with us? Hello, Prof. Alvin. I think there's been a connectivity issue. Oh.
On the pool of venom for the production of. Sorry, am I back?
Yeah, you're back.
Sorry.
Okay. Your connection is intermittent actually. But I think you've answered the question.
Which part?
You've generally answered the question. Okay, thank you.
Okay.
Okay, so that wraps up our Q&A session. And to close, we will be. We initially wanted to invite Professor Scott Weinstein from Australia to give some closing remarks, but he was unable to join us today. For the audience's information, Prof. Weinstein is a practicing clinical and research toxinologist, world-renowned actually, clinical and research toxinologist, family physician, and herpetologist, which is a reptile specialist. He's American, but he stays in Adelaide, Australia. So he sent us a video of closing remarks for the webinar, and we will play that right now.
Well, greetings to all the participants of this section of the Emergency Medicine Seminar Series on Clinical Toxinology. I have to express my heartfelt regrets that I could not participate, because of an unavoidable conflict that has prevented me from participating. So I'm sorry that I have to present this brief recorded commentary just as a general observation on the series and the efforts that are being made to maintain some very, very important interactions between clinical toxinologists and medical toxicologists and multiple interdisciplinary physicians and medical care providers through Southeast Asia and other countries. And I can only say that during the COVID pandemic, as we have seen, these are very, very important because it also keeps the human family in touch with the significant problems that are occurring in other parts of the world in which we become encapsulated in our own small cocoon in our given countries that have become and shrunken to actually have become to even a smaller ecology because of the pandemic, and therefore it is quite important that all of these participants have been involved and exchanging ideas and approaches to improve the delivery of compassionate and evidence-based medical care, and particularly towards our specific goal here in envenomings and poisonings. And it really is a singular type of effort because we also know that, of course, the different cultural differences between countries often gives us a window into improving the delivery of these services and appropriate management to patients in many, many different environments and from many different backgrounds. And so I think it's a fantastic thing to see that there's a very marked interest and participation in webinars like this that are being presented in this manner, and that there's a continuing effort to try to have this exchange of information and cultural identification of the needs in places that are underserved or do not have the degree of attention or financial support that are required. And I really also hope that these efforts that are being produced and all of the major problems that are being discussed that are often marginalized because they are not the major medical presentations, obviously, that occur even in a wide variety of environments, whether they be in an area of public health relevance for envenomings or not. We still, of course, have our trauma. We still, of course, have our diabetes and high blood pressure and acute coronary syndrome and COVID-related complications and all the other things that we see all the time. And so it's very important that this also remain highlighted and that it keeps the appropriate attention to this very, very specific and unfortunately often underserved problem. And so I applaud these webinars. I hope to participate in future ones, as I have on one or two occasions in related series such as this. And my great kudos to all the organizers and participants for giving what I have no doubt are very useful and, again, a window of presentation into regionally specific issues that are often not revealed or detailed to the greater audience at large, including health professionals in other global regions. So I do hope that everybody has gotten the things they have expected of this. I'm sure that everyone has learned from each other, and I would accentuate that many of the participating faculty, including myself, always learn things as well, because that's the beauty of teaching and writing is, of course, we learn as we do it. And so I do hope these will continue, and I look forward to the future ones that are being held. And I'm very privileged to be able to just provide a few general comments about how I hope that we continue to have these type of very, very useful exchanges that are all based on the goal to help patients get the best outcomes and get the appropriate compassionate treatments they deserve when affected by this type of very, very specific and problems that are very, very confronting to those who are often presenting with either snake bites, spider bites, or poisoning because they are less familiar to much of the medical staff. And so these have great import. So I wish everyone very, very well, stay safe, and I look forward to participating with you all in the future. Thank you very much.
Okay, thank you, Prof. Scott. So we can wrap it up, Daniel?
Yeah. Once again, the Secretariat would like to thank all of the panelists today for a vibrant and dynamic discussion. It's very inspiring to see all of these esteemed speakers on one screen. So we also would like to thank the audience for making this happen, and not least all of the co-organizers and collaborators. Before we go off, this is for okay. We have two QR codes here on the screen. On the left is for everybody watching the webinar. This is the QR code and the link to the e-certificate. So you're going to want to scan this, and it will lead you to a page where you have to fill in your details. And once again, please do not make any mistakes when filling out your particulars, especially your names and your email addresses. And on the right is specifically for Malaysians, myself included. I'm going to have to do this to claim your M&A CPD points for the webinar. So we're just going to leave this here on the screen for a few minutes, but otherwise we will be saying goodbye for now. And we hope to see you next time on the next edition of EMSS Emergency Medicine Seminar.